Hi everyone, this is Dr. Sakshi Arora Hans, your OBGY faculty at Marrow, and today I am here for a very important session, and that is all the important images in OBS and Gynae. I have compiled and brought them for you. Around 40 to 50 images were asked in the June FMG exam. Then the same was replicated in the NEET-PG exam. In NEET-PG also there were plenty of images. Keeping that in mind, this particular video is all about important images in OBS and Gynae. This video is important for all the students who are appearing not only for NEET or INI set, but extremely important for FMG students as well, right? So let's talk about all the important images in OBS and Gynae, in which first we are going to see all the important ultrasound images which are there in obstetrics, right? Now, when we talk about all the important ultrasound images in obstetrics, the first set of images are the ultrasound signs of early pregnancy. Now, in ultrasound signs of early pregnancy, the first sign in pregnancy is intradecidual sign, right? And this intradecidual sign is seen because of interstitial implantation, because the blastocyst implants, goes deep inside the endometrium and then implants, and this gives rise to the intradecidual sign, where what you are seeing is the gestational sac or the blastocyst which has gone deep inside the endometrium. So over here, this is the endometrium and you can see the blastocyst. It is the blastocyst which appears like a gestational sac. And how will it appear? It will appear like a black fluid-filled area surrounded by an echogenic rim. So that is the first sign of pregnancy on ultrasound. If they ask you first structure to be seen on ultrasound in pregnancy, then that's a gestational sac. But first sign on ultrasound is intradecidual sign. Then there is the double decidual sac sign. In double decidual sac sign, you will see that now the gestational sac is surrounded by two rings. The inner ring is formed by decidua capsularis and the outer ring is formed by decidua parietalis. And then we have, so over here you can see this is the black colored area, that is the gestational sac, and this is surrounded by two rings. Then over here, the next ultrasound, in the next ultrasound, you are seeing that inside the gestational sac, now we can see two bubble-like structures. I'm erasing so that you can see. This is what is called as the double bleb sign, and this is your INI-CET PYQ, which asked that in double bleb sign, what are the two blebs for? So one bleb or one bubble is for yolk sac, and the other one represents the amniotic sac. So these are the signs which are seen on ultrasound in pregnancy. Now, if they ask you what is the first structure which is seen in pregnancy on ultrasound, the first structure which is seen on pregnancy on ultrasound is gestational sac. This is followed by yolk sac. Right, so first structure is gestational sac, then yolk sac. After yolk sac, you can see the fetal pole, and when you can see the fetal pole, then crown rump length can be measured, and then you get the cardiac activity. This is the sequence in which structures are seen in pregnancy: gestational sac, then yolk sac, then fetal pole, and then cardiac activity. When gestational sac is seen, you can measure the mean sac diameter. Now, a very important question which they ask you is, what is the cutoff length of mean sac diameter to visualize the fetal pole or to measure crown rump length? And that is 25 millimeters. And what is the cutoff length of crown rump length to get cardiac activity? That is 7 millimeters. What is the critical titer of HCG to get a gestational sac in intrauterine pregnancy? On TVS, the critical titer is 2000 international units, and on TAS, it is 6500 international units. Then, next very important set of images are related to neural tube defects. Now, in neural tube defects, we have the cranial defects and the caudal defects. In cranial defects, if the brain tissue herniates out without any covering of skull, hair and scalp, then that is what is called as anencephaly. So, this over here is a specimen of anencephaly, right? Or if and why anencephaly happens, this is because the cranial neuropore fails to close, right? So brain tissue is going to herniate out. But suppose the cranial neuropore has closed. So this over here, suppose, is the neural tube. Now, anencephaly is going to happen because brain tissue is going to herniate out from the cranial neuropore when cranial neuropore fails to close. But suppose if cranial neuropore closes but brain tissue herniates out from some other smaller defect, then it will be covered by scalp and hair, and that is what is called as encephalocele. So this image over here is that of encephalocele. So next set of ultrasounds is related to anencephaly and encephalocele. So in anencephaly, on ultrasound, you are going to get triangular face. This triangular face is what is called as Mickey Mouse sign. So you can see over here, you are getting a triangular face. Plus, you are going to get irregular scalp lines. So over here, you are going to get irregular brain tissue which is herniating out, and this is what is called as shower cap sign. What is it called as? This is called as the shower cap sign, right? So you will have a triangular face which is called as the Mickey Mouse sign, then you will have the shower cap sign, and you will, on ultrasound, you are going to see big bulging eyes which is called as the frog eye sign. So over here you can appreciate this over here is the shower cap sign, then we have the Mickey Mouse sign, and there are the big bulging eyes which is called as the frog eye sign. It is very easy to distinguish this on ultrasound if it is this ultrasound is given. But sometimes you are given this view. In this view, what you have to see again over here, this is the shower cap sign, and you can see deep eye sockets which indicate that yes, the eyes are big and bulging, and that is what is called as the frog eye sign. So these are the signs which you get on ultrasound in anencephaly. Please remember, anencephaly is the first congenital anomaly which can be detected on ultrasound. Earliest anencephaly can be detected by 10 weeks on ultrasound, that is in first trimester. And for best diagnosis, ultrasound should be done at 14 weeks, that is in second trimester. If they ask you for anencephaly, what is the screening test? The screening test for anencephaly is level 1 ultrasound, and the diagnostic test for anencephaly is level 2 ultrasound. Level 2 ultrasound, which is also called as TIFA, that is targeted imaging for fetal anomaly, or it is also called as target scan. Please remember, target scan has to be done in all pregnant females between 18 to 20 weeks. Right? It should be done in all pregnant females, and this is the best ultrasound to detect gross congenital anomalies. Now, this over here is an ultrasound which is showing that brain tissue is herniating out from a small defect, right? And this is what is called as encephalocele. So this is an ultrasound which is showing you encephalocele. So in neural tube defects, we can have cranial defects, and then there can be caudal defects. Now, caudal defects are spina bifida. Everything about spina bifida you are being taught in your surgery classes. I am just reminding you over here that whenever there is a defect in vertebra, right? So if there is non-closure of the vertebra, and through that non-closure area, if only the meninges are herniating out, it is called as meningocele. Like over here, I have shown you that only this green color meninges are herniating out. But along with meninges, if the spinal cord is also herniating out, then that is what is called as meningomyelocele. Right? So now on ultrasound, how will you know whether it is meningocele or whether it is meningomyelocele? First of all, how do you know that it is spina bifida? Because you are going to see herniation which is happening from the vertebrae. So, and if you see that in the herniated sac, what you are getting, if it is jet black in color, that means it is meningocele. And if you see anything inside it, that means it's meningomyelocele. In this particular ultrasound, it's not jet black. There is something inside it. So this over here is meningomyelocele. Right? Now, in case of spina bifida, when you are doing ultrasound of head, then along with, you get two other signs on ultrasound of head in spina bifida. They are called as banana sign and lemon sign. What is lemon sign? Lemon sign is the frontal bossing. So if you see bossing of the frontal bones like this is what is called as lemon sign. And if you see cerebellum, downward displacement of the cerebellum, that is what is called as banana sign. So this over here, I hope you can appreciate the downward displacement of the cerebellum, and you can appreciate, which is called as banana sign, and frontal bossing, which is called as the lemon sign, right? Then this image has been asked in FMG exam, and earlier it was asked very oftenly in NEET-PG exam. This is a craniorachiasis. In craniorachiasis, there is both cranial and caudal defect. Please remember, to prevent neural tube defects, which vitamin has to be given? Folic acid has to be given. To prevent neural tube defect, the dose which you have to give is 400 micrograms. But to prevent the recurrence of neural tube defect, if the question comes that to prevent the recurrence of neural tube defect, what dose of folic acid has to be given? Then it has to be given 4 milligrams per day, right? And when you are giving the dose to prevent the neural tube defect, this has to be given in all pregnant females, and this should be given at least started 1 month before a female conceives, and it should be continued till 3 months after conception. Now, the dose which is given to prevent the recurrence of neural tube defect, this is given to pregnant females with previous history of neural tube defect in their babies. And in this case, you should give it at least 3 months before conception. Now, since we are obstetricians, we are not astrologers, that I can tell a female that 3 months from now you're going to become pregnant. That is why a better answer to this would be that whenever a female wants to conceive, whenever she comes to you and she's thinking about conceiving, you should start giving her folic acid. Right? Now, next set of images which I want to show you are related to abdominal wall defects. Again, this is a topic which you are taught very well in surgery, and you know that there are two very important abdominal wall defects. One of them is omphalocele and the other one is gastroschisis. In omphalocele, there is herniation of the abdominal content, and this herniation is going to happen in a sac. Whereas in case over here, you are seeing that herniation is happening in a sac, and that is why on ultrasound you are going to see that yes, abdominal wall is herniating out, but it has got a very well defined margin. On the other hand, if the abdominal wall content is herniating out and it is not enclosed in a sac, so if it is enclosed in a sac, it is called as omphalocele. Right? If it is not enclosed in a sac, it is called as gastroschisis. Now, in case of gastroschisis, on ultrasound, you are going to get a cauliflower-like appearance. Please remember that omphalocele is a central defect and it is associated with chromosomal anomalies. That is why whenever I am getting omphalocele, always and always I should be getting karyotyping done. Right? But if you are getting gastroschisis can happen to the left or to the right of the umbilicus. It is not necessary that it is going to happen from the umbilicus or it is going to happen from the center, and it is not associated with chromosomal anomalies. So you should not be getting a karyotyping done in case of gastroschisis. Right? Then, this image over here can be asked to you as a radio-obs surgery integration. Over here, you are getting a double bubble sign. In a double bubble sign, this is what you know. Again, in surgery, you've done that. This you get in case of duodenal atresia. Now, how are they going to link it to OBGY? Duodenal atresia is seen in case of Down syndrome. Number one, very, very important. And number two, whenever there is going to be duodenal atresia in the baby, there is going to be a swallowing defect. And that is why a complication which is seen in pregnancy because of duodenal atresia is polyhydramnios. So they can show you this image and they can ask you what possible defect can be in the baby and what complication can be there in the mother. So in the mother, it is going to lead to polyhydramnios. Another image which can be asked as a radio OBGY surgery integration is this image. What are you seeing over here? You are seeing a keyhole sign. Where do you get a keyhole sign? A keyhole sign is seen is posterior urethral valve. right? And again, please understand, whenever there will be a posterior urethral valve, there is going to be decreased urine output. And because there is going to be decreased urine output, in pregnancy, it leads to oligohydramnios. So that is how they can be linking radio OBGY and surgery, right? Then next image over here is the image which is showing you the plane in which abdominal circumference has to be measured. Whenever we are measuring abdominal circumference of the fetus, what we have to keep in mind is that 3 structures should be visible, and in that plane you have to measure the abdominal circumference. What are the 3 structures which should be visible? PUS, portal sinus, umbilical vein and stomach. So you can see over here, fetal stomach, then portal sinus and umbilical vein. This is what is making a hockey stick sign. So when you are seeing these 3 structures, portal sinus, umbilical vein and stomach, in that plane you have to measure the abdominal circumference, right? Please remember, abdominal circumference is the best ultrasound parameter for fetal growth. If they ask you which is the best ultrasound parameter to know IUGR, which is less growth, or to know macrosomia, which is excessive growth, the answer is abdominal circumference. If abdominal circumference is more than equal to 35 centimeters, that indicates macrosomia. Please understand, we are talking about abdominal circumference of the fetus, right? For measuring abdominal circumference of the mother, I need a measuring tape. I don't need an ultrasound to do that, right? Also, one thing which you have to remember is that whenever you are measuring the abdominal circumference, kidney and cord insertion should not be visible. 3 structures which should be visible are PUS, and 2 structures which should not be visible are kidney and cord insertion, right? Okay. Now, is there any better method? You know, this is the best ultrasound parameter to know about abdominal circumference. What is the best method to know about the estimated fetal weight? The best ultrasound method is if you are using formulas which is called as Hadlock formula and Shepherd formula. Next very important question is, can you clinically also estimate fetal weight? Yes. Clinically also we can estimate fetal weight by using Johnson's formula. Clear to all of you? Right. Next very important question is this image over here. In this image, what you are seeing, in this image, this is a typical image which is seen in case of ectopic pregnancy when a gestational sac is seen in the fallopian tube, and when you are going to switch on the Doppler, you are going to get a ring of fire appearance. Please, very, very important to understand is, ring of fire appearance is not diagnostic for ectopic pregnancy. It can be seen in corpus luteal cyst also. So if they show you this image and they say that a ring of fire appearance was seen, what is the next step? Don't say that once I get a ring of fire appearance, it means that the ectopic pregnancy is confirmed. No. Next step is you have to measure beta HCG. If beta HCG is more than equal to 2000 international units plus you are getting an empty uterus, that confirms that you are dealing with ectopic pregnancy. If beta HCG levels are less than 2000 international units, you should repeat beta HCG after 48 hours. After 48 hours, if you see that the values are nearly doubling, when I say nearly doubling, increase is roughly around 66%. So from 33 to 66%. If there is increase, but increase is less than 33%, or if there is a decrease in beta HCG. Now, if the values are nearly doubling, that means you are dealing with live intrauterine pregnancy. If the values are increasing, but the increase is less than 33%, that means it's a slow rise, then that means I'm dealing with ectopic pregnancy. And if the HCG values are decreasing, that means I am dealing with abortion. So the crux of the story is that whenever you are getting a ring of fire appearance or your question says basal sign positive, or your question says that there is empty uterus, or your question says that there is a complex adnexal mass, if your question is saying there is a ring of fire appearance, there is a basal sign positive, or there is empty uterus, complex adnexal mass, or your question is saying only gestational sac is seen in fallopian tube, none of these findings, beta, are diagnostic of ectopic pregnancy. Whenever your question is giving you any of these findings and they ask you what is the next step, your next step is measurement of beta HCG. So now I want all of you to tell me, is there any finding on ultrasound which is diagnostic of ectopic pregnancy? Yes. The finding on ultrasound which is diagnostic of ectopic pregnancy is if in fallopian tube you are getting gestational sac plus yolk sac. Only if your question says that you are getting gestational sac and yolk sac both in fallopian tube, that is diagnostic of ectopic pregnancy. And in this case, the next step is you have to go for management of unruptured ectopic. And the most common management for unruptured ectopic is medical management using methotrexate. Right? Clear to all of you? Okay, next image over here. This image is a typical image which is a snowstorm appearance which is seen on X-ray in case of H-mole. In which kind of H-mole do you get this snowstorm appearance? You are getting this in case of complete mole. Please remember, what is the karyotype of a complete mole? It is diploid and it is 46XX karyotype. Right? Now, in case of complete mole, on ultrasound, you get a typical snowstorm appearance. In case of partial mole, which is triploid and its chromosome number is 69XXY, in this case, when a partial mole, when you do an ultrasound, you get an image which resembles that of missed abortion or incomplete abortion. Right? Another very important point to note is that whenever you are going to get this ultrasound, the question is going to say that patient had increased HCG levels, then the height of the uterus was more than the period of gestation. Patient came to you with bleeding in first trimester or in early second trimester. They may say that patient had hyperemesis, or patient can have PIH, or your patient can have thyrotoxicosis. Right? So these are the this is how the patient is going to present to you in case of molar pregnancy. Right? Then, in case of molar pregnancy, please remember that molar pregnancy is a benign disease of the trophoblast, but it has malignant potential. The most common malignancy which is seen after H-mole is invasive mole. Next very important question is, what is the most common GTN malignancy, or they can say GTN, gestational trophoblastic neoplasia, which is seen after full term delivery? What is the most common GTN which is seen after full term delivery? The most common GTN which is seen after full term delivery is choriocarcinoma. If the question says choriocarcinoma most commonly occurs after, then your answer is choriocarcinoma most commonly occurs after molar pregnancy. And if they ask you PSTT, what is PSTT? Placental site trophoblastic tumor. That is again another type of GTN. There are 4 types of GTN. Number 1, invasive mole. Number 2, choriocarcinoma. Number 3, PSTT, which is placental site trophoblastic tumor. And number 4 is ETT, epithelioid trophoblastic tumor. If they ask you, PSTT most commonly occurs after, this most commonly occurs after full term delivery. Now, when it is a GTN can metastasize, and the most common site of metastasis is lungs. Whenever GTN metastasizes to lungs, that is stage 3. In which stage are the lungs involved? Stage 3. And in stage 3, when the lungs are involved, when you are going to do a chest X-ray, the most common appearance which you get of lung metastasis on chest X-ray is a cannonball appearance. So this over here is a cannonball appearance, and this over here is snowstorm appearance. Please do not say that the most common appearance of lung metastasis on chest X-ray is snowstorm. No, it is not. It is cannonball appearance. Clear to all of you? Then, this is the most common site for metastasis. What is the most common site for metastasis of choriocarcinoma or of GTN? It is lungs, followed by vagina. Right? So, the most common site for metastasis is lungs, followed by vagina. In vagina, when choriocarcinoma or when GTN is going to metastasize, it is going to metastasize just below the urethra, and it will appear in the form of a suburethral nodule. Vagina is involved in stage 2 and lungs are involved in stage 3. Right? Next over here, an ultrasound which is showing you ultrasound of twin pregnancy. This over here is the first twin and this over here is the second twin. Now, if you are seeing that in between the two twins, placenta is coming in the form of a peak. I am erasing so that you can see. If you see placenta coming in between the two twins in the form of a peak, that is what is called as twin peak sign positive. The other name is lambda sign positive. Twin peak sign or lambda sign positive is seen in dichorionic diamniotic twin pregnancy. But if you are seeing twins, so this over here is first twin, this is second twin, and this over here is placenta. Placenta is not coming in between the two twins in the form of a peak, and that is why this is twin peak sign negative. Twin peak sign negative, right? It is seen in case of monochorionic twins. Right, this is seen in case of monochorionic twins. Now, I want all of you to understand that how is a twin peak sign formed. So, if these are two twins, if this over here inside is amnion, outside is chorion. Right, so this over here is chorion, this is amnion, and this over here is the placental tissue. Now, if you see placental tissue coming in between the twins, this is what is twin peak sign positive, and this is seen in dichorionic diamniotic twin pregnancy, where you are getting twin peak sign positive, which is also called as lambda sign positive. Now, suppose I am drawing monochorionic diamniotic twins. So, this is a diagrammatic representation of monochorionic diamniotic twin. This is a monochorionic diamniotic twin. This over here is placental tissue. Now, placental tissue is not coming in between the twins. This is what is called as twin peak sign absent. But in case of monochorionic diamniotic twins, this amnion, right, amnion appears as if it is forming an inverted T sign with the placenta. So, in monochorionic twins, twin peak sign is absent. But in case of monochorionic diamniotic twins, T sign is positive. On the other hand, if you have monochorionic monoamniotic twin, monochorionic monoamniotic twin is like this. This is chorion, this is amnion, this is the twin. And this over here is placenta. Now, in case of monochorionic monoamniotic twin, neither is twin peak sign positive, neither is T sign positive. Both of them are negative. Very, very important. Now, if they ask you when should you be doing ultrasound for chorionicity, what is the best time to do ultrasound if you want to know chorionicity of the twins? Best time is 10 weeks to 14 weeks, right? Clear to all of you? Okay. Now, this image over here is showing you the measurement of the black colored area or the fluid filled area below the neck. This fluid filled area below the neck, this is what is called as nuchal translucency. Please remember, normally nuchal translucency is less than 3 millimeters. If nuchal translucency is more than equal to 3 millimeters, the next step is you should do karyotyping. For nuchal translucency, ultrasound is done between 11 weeks to 13 weeks plus 6 days. In other words, nuchal translucency has to be measured in first trimester. And when I am doing karyotyping, I need fetal tissue. So in first trimester, fetal tissue is obtained by chorionic villi sampling. So either in the options it will be written as, if nuchal translucency is more than equal to 3 millimeters, next step can be written as karyotyping, or next step can be written as chorionic villi sampling. That is one very important thing which you should remember. Please remember that the most common cause of increased nuchal translucency is Down syndrome, followed by Turner's syndrome. In other words, aneuploidy. Aneuploidy is a defect in chromosome number. Other than this, a second very important cause of increase in nuchal translucency is congenital heart disease. And the third very important cause is nuchal translucency is increase in nuchal translucency is an early marker of twin-to-twin transfusion syndrome in twin pregnancy. Now my question to you is, I did karyotyping. Karyotyping came out to be normal. Nuchal translucency was increased. We did a karyotyping. Karyotyping came out to be normal. Now what is the next step? Now if your question comes like this, that karyotyping result is normal but nuchal translucency is increased, what is the next step? Next step is you have to go for fetal echo. Why? Because a second most important cause is congenital heart disease. What is the time to do fetal echo? Time to do fetal echo is between 22 to 24 weeks of pregnancy. Now, an ultrasound which appears very, very similar to nuchal translucency, but over here the fluid collection is more and it is more widespread, and sometimes you can also see a septa. This is not nuchal translucency. Actually, this is a cystic hygroma. But the good point about cystic hygroma ultrasound is that cystic hygroma is a better marker for aneuploidy than nuchal translucency. So whether I am getting nuchal translucency more than 3 millimeters or whether I am getting a cystic hygroma, my next step has to be karyotyping. And again, cystic hygroma's second most common cause is congenital heart disease. So if I'm getting a cystic hygroma and again if I'm getting karyotyping normal, I have to do a fetal echo. Clear to all of you? Yes. Now, one very important thing which they can ask you is that up till which crown rump length should nuchal translucency be measured? In terms of gestational age, it's 11 weeks to 13 weeks plus 6 days. But in terms of crown rump length should be less than 84 millimeters. Then only you should be measuring the nuchal translucency. Clear to all of you? Next important over here. Now, this is a procedure where you have to see where is the needle going. In this procedure, you can see that the needle is going into placental tissue. In other words, it is going into chorionic villi. So, this is an image which is representing chorionic villi sampling. Remember, chorionic villi sampling has to be done at more than equal to 11 weeks. If it is done at less than 10 weeks, it can lead to oromandibular lymph defects. Fetal loss with chorionic villi sampling is 1%. If the question is what is the most common complication of chorionic villi sampling, answer is fetal loss. But if the question is what is the most common complication of chorionic villi sampling done at less than 10 weeks, then the answer is oromandibular defects. Now, in this image, see where the needle is going. In this image, the needle is going in the amniotic fluid. So, this is amniocentesis. When is amniocentesis done? Amniocentesis can be done any time between 15 to 20 weeks, but the best time to do it is 16 to 18 weeks. The chances of fetal loss with amniocentesis are less than 0.5%. That means amniocentesis is more safe than chorionic villi sampling. So whenever I want fetal tissue for karyotyping in second trimester, then I have to go for amniocentesis. Can amniocentesis be done in third trimester also? Yes, it can be done in third trimester for managing polyhydramnios, number one, and if for lung maturity test. All lung maturity tests are done on amniotic fluid. In lung maturity test, they can ask you which is the best lung maturity test. The best lung maturity test, do not say it is lecithin upon sphingomyelin ratio. Best lung maturity test is you have to look for presence of phosphatidylglycerol in amniotic fluid. Right? If phosphatidylglycerol is present in amniotic fluid, lungs of the baby are mature. If phosphatidylglycerol is absent in amniotic fluid, lungs of the baby are not mature. The most commonly done test is lecithin upon sphingomyelin ratio. If lecithin upon sphingomyelin ratio is more than 2:1, then the lungs of the baby are mature. Please remember this question they ask you in this format, that what is the best test to be done in diabetic mothers to know that the lungs of the baby are mature, whether it is diabetic mother or non-diabetic mother. Best test for lung maturity always is phosphatidylglycerol. Another thing which I want to tell you is, in amniocentesis, when you do amniocentesis, you can also check the levels of alpha fetoprotein, and that is why amniocentesis can detect neural tube defect, whereas in case of chorionic villi sampling, you cannot detect neural tube defect. Nevertheless, if they ask you what is the best investigation for neural tube defect, it has to be ultrasound. Next very important question which they can ask you is that what is the best biochemical marker for neural tube defect? The best biochemical marker for neural tube defect is not alpha fetoprotein, it is acetylcholine esterase. Next question is, when should you be measuring alpha fetoprotein? What is the time to measure alpha fetoprotein? Again, the time at which you are doing amniocentesis. That means between 15 to 20 weeks, or the best time is between 16 to 18 weeks. Clear? Now, in this image, what you are seeing? In this image, you are seeing this over here is the bladder. Right, and I am seeing that via the posterior fornix, we are entering into a needle has been taken into the cul-de-sac or the pouch of Douglas. This is called as culdocentesis. This procedure is culdocentesis. When do you do it? You do it in case of ruptured ectopic, where via the posterior fornix, a needle is inserted into the cul-de-sac, and whatever blood comes out, we are going to keep it. On keeping, if blood clots, that means your needle had entered an artery or a vessel. Your needle had entered any vessel. This blood has not come from hemoperitoneum. If blood does not clot, that means yes, there is hemoperitoneum. In other words, there is ruptured ectopic if urine pregnancy test is positive. Right? Why is it that in case of ruptured ectopic, the blood will not clot? This is because whenever the ectopic is going to rupture, all the clotting factors will try to control the bleeding, but they will not be able to control the bleeding, and in turn, all the clotting factors will be consumed, and that is why blood will not clot on keeping in case of ruptured ectopic or in case of hemoperitoneum. This is an image which they had shown you this time in NEET-PG. This is how a karyotyping result comes to you. Whenever you get a karyotyping result, you have to see whether all the autosomes are in pair, or is there any one less or one more. If in this case what you are seeing that there is one extra chromosome, and that extra chromosome belongs to chromosome number 21. That means this is showing trisomy 21. And because this is X and Y karyotype, so this means the child is a male child. So it is a Down syndrome male baby. And this was your karyotype result A. This is karyotype B. In this karyotype, what I'm seeing that all chromosomes have a pair, but I am seeing only one sex chromosome. So this is 45XO and that chromosome is X. This is what is called as monosomy X or Turner's syndrome. Right? Now tell me, how is the sex of the baby designated? The easiest way or the most commonly used method for sex determination is by looking at external genitalia. But sometimes by looking at external genitalia, you cannot decide the sex of the baby. And why? Because that you cannot say whether the baby is male or female, and that is what is called as ambiguous genitalia, right? Now, this is the most commonly used method. Then what is the best method for sex determination? Best method for sex determination is you have to look at Y chromosome. On Y chromosome, SRY gene is present, which is present on the short arm of Y chromosome on the distal end. If Y chromosome is present, you say that the sex of the baby is male. If Y chromosome is present, SRY gene will be present. That means the baby is going to be a male baby. If Y chromosome is absent, that means SRY gene will be absent and the sex of the baby will be a female baby. So in case of Turner's syndrome, which is 45XO, karyotypically they are female babies, whereas Klinefelter's syndrome, which is 47XXY, it is male baby, right? Because they have Y chromosome. Now, there is one more method of sex determination, and that is by counting the number of Barr bodies. How do you calculate the number of Barr bodies? Barr bodies is the number of X chromosomes minus 1. So, in a normal female, the number of Barr bodies will be 1 because their chromosome number is 46XX, and in a normal male, the Barr bodies will be 0. Now, in case of Turner's syndrome babies are 45XO. Although we are saying they are female babies, the number of Barr bodies are going to be 0, right? This is what is called as false negative Barr body. Right? This is a false negative Barr body. Actually, this is a false negative result. The baby has to be designated as a female child, but Barr body is coming as 0. On the other hand, if you look at Klinefelter's syndrome, in case of Klinefelter's syndrome, which is 47XXY, you are getting the number of Barr body is 1, but they are taken as male child, right? But the number of Barr body is 1, and this is what is called as false positive Barr body. Clear to all of you? So we have a false negative Barr body and false positive Barr body. Next very important set of images are images which come on Doppler. Now this particular Doppler is Doppler showing of uterine artery. In Doppler of uterine artery, this over here is the systole and this over here is diastole. Just before diastole, do you see a diastolic notch? So always you are going to get a diastolic notch on Doppler of uterine artery. This diastolic notch normally disappears by 22 to 24 weeks of pregnancy. If this diastolic notch persists, then it means that during this pregnancy, your patient is going to have PIH. So the role of uterine artery Doppler is that it is going to predict that the patient develops PIH. So normally uterine artery Doppler is done between 22 to 24 weeks. These days we have started doing Doppler even earlier between 11 to 13 weeks. Between 11 to 13 weeks in all pregnant females, you are going to get a diastolic notch. What we are looking at is not diastolic notch between 11 to 13 weeks. Between 11 to 13 weeks, we are looking at pulsatility index. If between 11 to 13 weeks on uterine artery Doppler, if pulsatility index is increased, this means that your patient is going to have early onset preeclampsia, and this is your INI-CT PYQ. right? Other than uterine artery Doppler, you should be knowing umbilical artery Doppler findings as well. Images related to umbilical artery Doppler. Umbilical artery Doppler, it is done for PIH, IUGR and uteroplacental insufficiency. In umbilical artery Doppler, we have to look at the SD ratio. Please remember, normally, as pregnancy advances, blood flow during diastole increases. Why blood flow during diastole increases? Because blood flow during diastole depends on the vasoconstrictors and vasodilators which are present in mother's blood. So normally in pregnancy, the main hormone is progesterone, which is a smooth muscle relaxing hormone. Right? So when the resistance is going to decrease, all of you know pressure and volume are inversely related. So as pregnancy is going to advance, because of progesterone, the pressure is going to decrease. It means volume of blood is going to increase during diastole. So imagine if in pregnancy, during systole, this much blood was going, and in early pregnancy, during diastole, this much blood was going. Right? Now, as pregnancy is going to advance, the blood flow during diastole is going to increase. So, what is going to happen to SD ratio? If the denominator is increasing, what will happen to the ratio? The SD ratio is going to decrease. So, normally as pregnancy advances, SD ratio decreases. But in patients of PIH, SD ratio increases and it becomes more than 3. Whenever SD ratio in umbilical artery Doppler becomes more than equal to 3, this means this is equivalent to mild preeclampsia and the pregnancy should be terminated at 37 weeks. Now suppose that pressure during diastole becomes very high. If pressure during diastole becomes very high, then during diastole, no blood is going to flow. Understand, during systole, it doesn't matter how much is the pressure. This is because during systole, heart is actively contracting and pushing blood into a blood vessel. It is during diastole that it is a passive phenomena, and because during diastole it's a passive phenomena, it depends on how much resistance is being offered by the blood vessel. If the blood vessel will offer more resistance, blood flow during diastole will decrease. If the blood vessel will offer less resistance, blood flow during diastole will increase. Right? Now I am saying that the resistance which is offered during diastole is so high that there is no blood flow happening during diastole. This is what is called as absent end diastolic flow. So in this Doppler image, you are seeing that during diastole, there is absent blood flow. This is called as absent diastolic flow. If you are getting an image like this, then pregnancy has to be terminated between 33 to 34 weeks. Now imagine an extremely serious situation where during diastole, the pressure or the resistance is so high that instead of blood coming inside the blood vessel during diastole, blood is flowing away from the blood vessel. And this is what is called as reversed diastolic flow. So this over here, during systole, blood flow is in this direction, but during diastole, it's in opposite direction. This is what is called as reversed diastolic flow. Whenever you get a reverse diastolic flow, pregnancy has to be terminated between 30 to 32 weeks. So now if I ask you that you are getting this kind of a Doppler, absent end diastolic flow or reverse diastolic flow, but the pregnancy is 28 weeks, how are you going to manage? If pregnancy is less than the period at which termination has to be done, then first of all, you have to give corticosteroids to the baby for lung maturity, and you have to go for NST daily, umbilical artery Doppler every 2 to 3 times in a week, and you have to do ultrasound for fetal growth after every 3 weeks. All the Marrow subscribers, all of you know that I tell you in all high risk pregnancies, whether it is PIH, whether it is anemia, whether it is diabetes, you have to start antepartum fetal monitoring from 32 weeks onwards. And what are the components of antepartum fetal monitoring? You have to do NST, you have to do biophysical score, and you have to do ultrasound for fetal growth. right? The only difference is the frequency. So in this case, how frequent are you going to do NST? NST has to be done daily. How frequency are you going to do biophysical score? You have to do biophysical score daily. How frequently are you going to do ultrasound for fetal growth? You have to do it after every 3 weeks. And how frequently are you going to repeat an umbilical artery Doppler? You have to repeat it in a week at least 2 to 3 times. Same thing you are also going to go do if it is a reversed diastolic flow, right? Then coming to important images of placenta. This over here is the fetal side of the placenta. How do you identify the fetal side of the placenta? Fetal side of the placenta is going to be shiny, and you will see that the umbilical cord is attached to the center of the fetal side of the placenta. Fetal side of the placenta forms 4/5 of the placenta, and it originates from chorion frondosum. On the other hand, this is the maternal side of the placenta. How do you identify maternal side of the placenta? In maternal side of the placenta, which is dull gray in color, you are going to see polygonal areas which are called as lobes. Each lobe is further divided into a lobule or a cotyledon, and please remember the functional unit of the placenta is a cotyledon. From where is the maternal side of the placenta derived? Maternal side of the placenta originates from decidua basalis, right? Now this is how a normal placenta looks like. Coming to placental anomalies, if instead of the cord being attached to the center, if cord is attached to the margins of the placenta, such a placenta is called as battledore placenta. If a placenta is divided into 2 lobes and both these lobes are connected by blood vessel and both these lobes are almost equal in size, it is called as placenta bilobata. If you are getting a placenta where placenta is divided into one big lobe and another small lobe and both of them are connected by blood vessels, then this is called as placenta subcancuriata. Just now I told you, normally it is the fetal side which forms 4/5 of the placenta and maternal side forms 1/5 of the placenta. Now suppose there is a placenta where fetal side is small and maternal side is big, so that the maternal side is surrounding the fetal side in the form of a ring. So if this over here is fetal side of the placenta and the fetal side of the placenta is surrounded by maternal side. So we have 2 situations over here. Fetal side of the placenta surrounded by maternal side of the placenta. Now, while the maternal side of the placenta is surrounding the fetal side of the placenta, if you get a valve-like thickening between them, then that is called as circumvallate placenta. Remember, V for valve, V for vallate, right? And if there is no valve-like thickening, then that is called as circummarginate placenta. Right, so this over here is a circumvallate and this one was a circummarginate. A next condition could be that suppose there is a placenta, right? Now the cord is not getting attached directly to the placenta. Cord stops some distance before it gets attached to the placenta, and the cord is getting attached to the membranes. It is not directly getting attached to the placenta. So this over here was the placenta. Cord is not directly getting attached to the placenta. It is first attaching to the membranes. In the membranes, the blood vessels are then losing their Wharton's jelly, and the blood vessels, what are the blood vessels which are found in umbilical cord? 3 blood vessels. Earlier in pregnancy, there are 4 blood vessels which are right umbilical artery, right umbilical vein, left umbilical artery, left umbilical vein. But as pregnancy advances, the right umbilical vein disappears, only left is left behind. So there are 3 blood vessels. Now these 3 blood vessels are going to lose their Wharton's jelly, that is the connective tissue, and they are directly going and attaching to the placenta. This is what is called as velamentous insertion of the cord. Velamentous insertion of the cord can also be represented like this. So if this over here is the uterus, this is the placenta, these are the membranes, right? This over here is the fetus. Now, velamentous insertion can also mean that the cord is first getting attached to the membranes. There it is losing its Wharton's jelly, and then the blood vessels are going and getting attached to the placenta. This is also how you can represent velamentous insertion of the cord. Velamentous insertion of the cord can lead to a very serious situation, that is vasa previa. Plus, it can lead to cord compression. Why it can lead to cord compression? It can lead to cord compression because the blood vessels are losing their Wharton's jelly, they are losing their connective tissue, so now they are more prone to compression. And remember, whenever the cord of the baby is getting compressed, then on CTG, what finding do you get? You get variable decelerations. Right? Okay, so let me show you all of these anomalies. Over here, what you are seeing, you are seeing that the cord is getting attached to the margins of the placenta. This is called as battledore placenta, or this is called as marginal insertion of the cord. This is your PYQ. In this case, what you are seeing? In this case, you are seeing that the cord is getting not directly attached to the placenta, but it is first attached to the membranes, and the blood vessels are then separating and they are going and getting attached to the placenta. This is what is called as velamentous insertion of the cord. Same thing you are seeing over here in this image, that the cord is attached to the membranes and these blood vessels are then going and getting attached to the placenta. So this is also velamentous insertion of the cord. Right? Next image over here, you are seeing that the placenta is divided into two lobes which are appearing almost equal, and I can see connecting blood vessels. Right? So this over here is placenta bilobata. Why am I not calling it as a placenta of twin pregnancy? Because I can see only one umbilical cord. I'm not getting two umbilical cords. In twin pregnancy, there will be two umbilical cords. In this image, what you are seeing, in this image, you are seeing that there is a big side lobe of the placenta and there is a small lobe of the placenta, and both of them are connected by blood vessels. This is placenta subcutariata. Please remember, placenta bilobata and placenta subcutariata can give rise to PPH. Over here, what I am seeing, I am seeing that this is the fetal side of the placenta, this is the maternal side of the placenta, and I am seeing a valve-like thickening which is separating the fetal side and the maternal side. This over here is circumvallate placenta. Right? Now, these images, what are you seeing in these images? In these images, you are seeing that there are two umbilical cords. Whenever there are two umbilical cords, that means these placentas, they belong to placenta of twin pregnancy. Now, just now I had made you draw dichorionic, diamniotic, monochorionic, diamniotic and monochorionic, monoamniotic twins. Quickly draw them again with me. So, first we are going to draw dichorionic, diamniotic twins. Right, so this is dichorionic, diamniotic twin. Outside chorion, inside amnion. This is dichorionic, diamniotic. When is a dichorionic, diamniotic twin formed? A dichorionic, diamniotic twin is formed from all dizygotic twins. All dizygotic twins are dichorionic, diamniotic, and monozygotic twins, when they divide in less than 4 days, then they form dichorionic, diamniotic twins. Then we have monochorionic, diamniotic. So, monochorionic, diamniotic twins. This is a monochorionic diamniotic twin pregnancy. A monochorionic diamniotic twin pregnancy will be formed when a monozygotic twin divides between 4 to 8 days. Then we have monochorionic monoamniotic twins. Monochorionic monoamniotic twins, this is chorion, this is amnion. This is formed when a monozygotic twin divides between 8 to 12 days, and then you are going to have conjoined twins. Please remember, they can ask you what is the specific complication of monochorionic diamniotic twins. It is twin-to-twin transfusion syndrome. And what is the specific complication of monochorionic monoamniotic twins? It is cord entanglement. And that is why monochorionic, monoamniotic twins and conjoined twins. Conjoined twins are a variety of monochorionic, monoamniotic twins. Both of them have to be delivered by cesarean section between 32 to 34 weeks after giving the baby steroid covers. Now, why I have made you draw these diagrams is I want all of you to see how many layers of membranes are present between the twins and dichorionic, diamniotic. There are 4 layers of membranes. In other words, they are thick membranes. In case of monochorionic diamniotic, there are 2 layers of membranes. In other words, they are thin membranes. And in monochorionic monoamniotic, there is no membrane. Now, when I have to identify the placenta, same thing, I have to see whether the membrane between the 2 umbilical cords is thick, whether it is thin, or whether no membrane is present. If membranes are thick, then you are looking at a placenta of dichorionic diamniotic twin. In dichorionic diamniotic twin, the time of delivery is 38 weeks. You can go for vaginal delivery or cesarean section depending upon the presentation of first twin. Right? Then, this over here, you are getting thin membrane. Because you are getting thin membrane, this is monochorionic diamniotic twin. In monochorionic diamniotic twin, the time of delivery is between 34 to 37 weeks. 34 weeks if twin-to-twin transfusion syndrome is present, and 37 weeks if twin-to-twin transfusion syndrome is absent. Again, you can go for vaginal delivery or cesarean section depending upon the presentation of first twin. Then in this placenta over here, I am not getting any membrane between the cords. That means it is a placenta belonging to monochorionic monoamniotic twin pregnancy. As I told you, in monochorionic monoamniotic twin pregnancy and in conjoined twins, you have to deliver them between 32 to 34 weeks by cesarean section. Clear to all of you? So these are the placental images related to twin pregnancy. Then the other placental images which they can ask you is placenta previa, the type of placenta previa. If you are seeing that the placenta is in lower uterine segment and it is within 2 centimeters of internal os, but it is not reaching up till the level of internal os, that is called as type 1 placenta previa. Type 1 placenta previa is also called as lateral placenta previa. If you are seeing that the placenta is reaching up till the margins of internal os, that is type 2 placenta previa, which is also called as marginal placenta previa. If you see that the placenta is partially covering the internal os, that is type 3 placenta previa, which is also called as incomplete placenta previa. And if you see it is completely covering the os, that means it is a complete placenta previa or it is central placenta previa. So this over here is the older classification for placenta previa, that is type 1, type 2, type 3 and type 4. It's not grade, it's type 1, type 2, type 3, type 4. Right now in the newer classification, type 1 is called as low-lying placenta. Type 1 is called as a low-lying placenta. Type 2, 3 and 4. All of them come under placenta previa. Right, that is the newer classification. Clear to all of you? Now, this over here are images showing to you abnormal insertion of chorionic villi in the placenta, which leads to placenta accreta spectrum. In placenta accreta spectrum, there is number 1, Nita-Bucks layer is absent. Right, and number 2, there is defective decidua basalis. Now, if you see that the chorionic villi are superficially attached to the chorionic villi, they are superficially attached to myometrium, then that is what is called as placenta accreta. If you see that it is deep inside the myometrium, it is invading the myometrium, right? So, if chorionic villi invade the myometrium, then that is placenta increta. And if you see that the chorionic villi have reached the level of serosa, chorionic villi have reached the level of serosa, then that is placenta percreta. Please remember, amongst them, the most common one is placenta accreta. Now, what is the two most important risk factors? The two most important risk factors in case of placenta accreta spectrum are previous history of cesarean section and in present pregnancy if there is placenta previa. Please remember, previous history of cesarean section, previous history of any uterine surgery, previous history of any excessive curettage, all of them are risk factors. So in order to confuse you, they will say all of the following are risk factors for placenta accreta except option A, previous history of cesarean section, option B, previous history of myomectomy, option C, previous history of curettage, option D, previous history of placenta previa. Please remember, previous history of placenta previa is not a risk factor for placenta accreta spectrum. It is present pregnancy may patient should be having placenta previa. Right, that is a risk factor for placenta accreta. A patient of placenta accreta will present to you with intractable PPH. No matter how much you try to control the PPH will not be controlled because placenta will not get removed. And that is why the management is hysterectomy. Right? Now, this was a question which was asked in your NEET-PG 2024. A G2P1 with previous history of breech delivery who underwent LSCS, which was uneventful, currently came with antepartum hemorrhage. She was taken for LSCS during which she lost a lot of blood. An obstetrical hysterectomy had to be carried out. Image of the uterus is given. So, you are seeing over here in the uterus, the placenta is still attached. So, that means the obstetrician would have tried to remove the placenta, but the placenta did not get removed. In other words, it's a case of placenta accreta syndrome. They have written it is placenta accreta spectrum. Clear to all of you? Okay. Now coming to images which show you teratogenic effects of the fetus. Now, this image over here is showing you aplasia cutis, and this is caused if methimazole or carbimazole is taken in first trimester. So, if they ask you what is the drug of choice for hyperthyroidism in pregnancy, please remember the drug of choice for hyperthyroidism in pregnancy is propylthiouracil. If they ask you what is the drug of choice for hyperthyroidism in first trimester, again, it is propylthiouracil. In second and third trimester, it is methimazole or carbimazole. Right? Okay. Then, this over here is an image which is showing you fetal alcohol syndrome. In fetal alcohol syndrome, you get a triad of microcephaly, growth restriction and facial features. There are typical facial features which you get in fetal alcohol syndrome fast, which are short palpable fissures. The eyelids over here, this is a short palpable fissure. There will be thin upper lip, thin vermilion border, and there is going to be indistinct philtrum. This over here, this cut is not going to be there. So there will be indistinct philtrum. These are typical facial features which you get in a fetus if mother consumes alcohol during pregnancy, and that is what is called as fetal alcohol syndrome, where you are going to get microcephaly, you are going to get growth restriction and typical facial features constituting short palpable fissures, then indistinct philtrum and thin vermilion border. Now, in this image, what you are seeing? In this image, you are getting skin lesions, right? So, there are cicatricial skin lesions and the limbs of the baby are contracted. This is how the image is going to be given, and this is how they are going to describe it, that there is cicatricial skin lesion. Whenever they use this term cicatricial skin lesion and limb contractures, this means you are dealing with neonatal varicella syndrome. Right? Neonatal varicella syndrome occurs if mother acquires chicken pox 5 days before or 2 days after delivery. Then this results in neonatal varicella syndrome. Now, in this image, what you are getting, whenever you are getting proximal limb amputation, right? So, whenever the limbs of the baby are amputated and you get an image like this, please remember that this is phocomelia, which has happened because of thalidomide ingestion by the mother. This phocomelia should always be distinguished from amniotic band syndrome. In amniotic band syndrome, which is also called as Streeter's syndrome, you get digit amputation. Why is this digit amputation happening? This is happening because of preterm premature rupture of membranes, which is going to lead to severe oligohydramnios, and the membranes, they wrap tightly around the fetus, causing constriction band and leading to distal digital amputation. So whenever you are getting distal digit amputation, it means you are looking at constriction band syndrome or amniotic band syndrome or Streeter's syndrome. And a distinguishing feature over here will be not only the digits are amputated, you are also getting that the membranes are tied around the digits tightly like a rubber band. Right? Clear to all of you? Now, over here in this image, what you are getting? In this image, you are getting depressed nasal bridge and you are getting stippled epiphysis. Whenever you are getting depressed nasal bridge or stippled epiphysis, this means mother had consumed warfarin in first trimester, and this is warfarin embryopathy. Remember, if warfarin is consumed in first trimester more than equal to 5 milligrams, then it leads to warfarin embryopathy. This warfarin embryopathy is also called as DeSala's syndrome, and in DeSala's syndrome there is chondrodysplasia. What do you understand by chondrodysplasia? The cartilage of the baby, cartilage at various places is not properly developed, right? Now, what are you seeing over here? In this image, you are seeing caudal regression syndrome, which is also called as sacral agenesis. Caudal regression syndrome or sacral agenesis is seen if mother has pre-gestational diabetes. Please remember, gestational diabetes does not lead to congenital malformation. Congenital malformations are not caused by gestational diabetes. Now, if they ask you what is the most common system which is involved in babies of diabetic mother, it is cardiovascular system followed by central nervous system. Most common congenital malformation is VSD followed by neural tube defect, but the most specific one is caudal regression syndrome or sacral agenesis. If they ask you most common cardiovascular anomaly, it is VSD. But if they ask you most specific cardiovascular anomaly, it is TGA, transposition of the great artery. Now, this is if they ask you what is the most common cardiovascular anomaly, then you have to answer it as VSD. If they ask you what is the most common cardiovascular finding, what is the difference between anomaly and finding? Anomaly does not resolve after delivery, whereas finding is reversible after delivery. So most common cardiovascular finding in case of pre-gestational, in case of babies of mothers of pre-gestational diabetes is HOCM, right? Hypertrophic cardiomyopathy, HOCM. Now, coming to important maneuvers. In maneuvers, first of all, maneuvers related to shoulder dystocia. Now, these are all the maneuvers which are related to shoulder dystocia. Please remember, shoulder dystocia is an obstetrical emergency and there is an algorithm for managing shoulder dystocia. The steps have to be carried out in this manner only, and it has the acronym for it is HELPER, HELPERR, right? So I want all of you to revise HELPER because questions on HELPER are very oftenly asked. Now, in this HELPER, L stands for legs maneuver, which is also called as Mac-Roberts maneuver. In Mac-Roberts maneuver, what do we do? In Mac-Roberts maneuver, we ask two of our assistants to take out the legs of the mother from the lithotomy position, from the stirrup, and to flex them tightly against the abdomen and then to abduct them. So once they are flexing the legs tightly against the abdomen and then abducting them, what is happening? It leads to straightening of the sacrum and that increases the available space. So this over here is Mac-Roberts maneuver. Please remember, initially when you perform Mac-Roberts maneuver, you do not apply suprapubic pressure. Initially, you are going to perform Mac-Roberts maneuver without suprapubic pressure. But if Mac-Roberts maneuver fails, then you ask the assistant to apply suprapubic pressure and along with Mac-Roberts maneuver, and you try to deliver the shoulder. Right? So once in FMGE, rather last time only, they had asked a question that Mac-Roberts maneuver has failed. What is the next step? And many students had marked the next step as Wood's corkscrew maneuver. maneuver. Please remember, when Mac-Roberts maneuver fails, the next step is suprapubic pressure. It is not Wood's corkscrew method. What is a Wood's corkscrew maneuver? Wood's corkscrew maneuver is, we all know whichever part has to be delivered, it should lie directly behind the pubic symphysis. So when the shoulders are not getting delivered, I am presuming that maybe the shoulders are not rotated properly. They are not lying directly behind the pubic symphysis. So I am going to take my hand inside and I am going to rotate the shoulder of the baby, and this is what is called as Wood's corkscrew maneuver, where you will see an image where you are taking your hands inside and you are rotating the shoulder of the baby. This is Wood's corkscrew maneuver, right? Then another maneuver which you can do is, you can ask the patient to roll on all four limbs and then you can try to deliver the baby. This is called as, you can try to deliver the shoulders, not the baby, sorry. You can try to deliver the shoulders. This is called as all four maneuver, or it is called as Gaskin's maneuver. Right, so this image over here is all four maneuver or Gaskin's maneuver. Please remember that in shoulder dystocia, what is the last resort? Last resort is Zavanelli's maneuver. What is Zavanelli's maneuver? Zavanelli's maneuver is the head which has been delivered. I'm going to push it back inside the mother's uterus, followed by a cesarean section. What is contraindicated in shoulder dystocia? Fundal pressure is contraindicated in case of shoulder dystocia. What is the most common nerve which is injured during Mac-Roberts maneuver? Lateral cutaneous nerve of thigh, leading to myalgia paresthetica. That is the most common nerve which is injured during Mac-Roberts maneuver. What is the most common fetal complication of shoulder dystocia? Most common fetal complication of shoulder dystocia is Erb's palsy, which involves nerve root C5 and C6. What is the most common maternal complication of shoulder dystocia? It is PPH. Clear to all of you? Okay, now coming to another set of maneuvers which are very, very oftenly asked in image-based exams, and that is Leopold maneuver. For a detailed understanding of Leopold maneuver, I would request all of you to watch the video which I have shared on my YouTube channel on Leopold maneuver, and your understanding for Leopold maneuver in that 10-minute video will be very, very clear. Now, Leopold's maneuver, there are four maneuvers in Leopold's: first, second, third and fourth. Please remember, first, second and third, they are done while you are facing the face of the patient, and fourth one is done while you are facing the feet of the patient. In the Leopold's first maneuver, you are going to take both your hands in the fundal area of the uterus, and this is what is called as fundal grip. Now, in Leopold's first maneuver, if it is empty, that means there is transverse lie. If anything can be felt, that means it's a longitudinal lie. So, Leopold's first maneuver, which is also called as fundal grip, it tells you about the lie of the fetus. Now, depending upon what you are feeling, if you on fundal grip, you are feeling broad, irregular, soft fart, that means you are feeling the breech, right? That means you are feeling the buttocks of the baby, and that means buttocks of the baby are up, so head of the baby has to be down, and that means it's a cephalic presentation. But if on Leopold's first maneuver or fundal grip, if you are feeling hard globular structure, that means you are feeling the head of the baby, and that means presentation is breech. So Leopold's first maneuver, which is called as the fundal grip, tells you about the lie of the baby, and it tells you about the presentation of the baby. Now, from the fundal area, you are going to bring your hands to the lateral side. That means near the umbilicus. This is called as umbilical grip or lateral grip. Umbilical grip or lateral grip, it tells you about the position of the fetus. On one side in lateral grip, you are going to feel the back of the baby. Back of the baby gives you a smooth, regular, curve, board-like rigidity. And on the other side, you are going to feel, so on one side, you are going to feel the back. On the other side, you are going to feel the limbs. Limbs give you multiple knob-like feeling. On the side where back is present, occiput will also be present. So if back is present on the left side, the position of the baby has to be LOA, LOT or LOP. And if back is present on the right side, then the position of the baby has to be ROA, ROT or ROP. P. That means Leopold's second maneuver tells me about the position of the baby, and this is what is called as lateral grip or umbilical grip. Now in the Leopold's third maneuver, you are going to take your one hand above the pubic symphysis area and you are going to feel what can be felt. This is what is called as the Folic grip, or it is called as Leopold's third maneuver. Folic grip or Leopold's third maneuver again tells you about presentation, and then it also tells you whether the head of the baby has entered the pelvis or not. In other words, whether the head is ballotable or not. It will tell you, with the help of ballotability, it will tell you whether the head has entered the pelvis or not. Right? Now, till this time, you were facing the face of the patient. Now you are going to face the feet of the patient and you are going to perform Leopold's fourth maneuver, which is also called as the deep pelvic grip. In deep pelvic grip, in the image, you will see two hands near the pelvic area. In Leopold's third maneuver, you will see a single hand near the pelvic area. If you are seeing a single hand near the pelvic area, that means it is Leopold's third maneuver or the Folic grip. And if you are seeing two hands near the pelvic area, that means it's Leopold's fourth maneuver or the deep pelvic grip. Again, deep pelvic grip or Leopold's fourth maneuver, it confirms the findings of Leopold's third maneuver. That means it is going to tell you what is the presentation and whether the head has entered the pelvis or not. And one additional thing which Leopold's fourth maneuver tells you is about the attitude of the fetus. So these are Leopold's maneuvers, very, very important. Depending upon the position of the hand, you can tell whether it is the fundal grip or whether it's the umbilical grip or whether it is the Folic grip or the deep pelvic grip. Clear to all of you? Then, there is only single maneuver which you have to remember for delivering the head of the baby in a normal vaginal delivery. So when you see that the head of the baby is being delivered, that means in a normal vaginal delivery, there is only one maneuver, and that is modified Rittigen maneuver. In modified Rittigen maneuver, with one hand you have to support the perineum, and with the other hand you have to first flex the head of the baby. First, you have to flex the head of the baby so that the smaller diameter comes out first, and then you have to extend it. Right? And with one hand, you have to do this. With the other hand, you have to support the perineum. This is what is called as modified Rittigen maneuver. Right? This is the only maneuver which is done in case of normal vaginal delivery. Now, coming to maneuvers which are done in breech, they are very, very easy to identify because what you have to see is which part is being delivered. If in breech you see that fingers are taken in the groin area and the buttocks are visible, that means it is groin traction, and groin traction is done for delivering the buttocks in case of flexed breech. Right? In the second image, what I am seeing that the leg of the baby is extended. So this is a case of frank breech. Please remember, flexed breech means that the hip joint is also flexed and knee joint is also flexed. Frank breech means hip joint is flexed but knee joint of the baby is extended. Now, if it is a case of frank breech and you are seeing that two fingers are being taken up till the popliteal fossa. So, two fingers are being taken up till the popliteal fossa. P for popliteal fossa, P for Pinard's maneuver. This is what is called as Pinard's maneuver, and this is for delivery of extended legs in case of breech. Right? Now, one more very important thing which I want to ask and tell you is, if they ask you what are the maximum chances, in which case are the maximum chances of cord prolapse. So please remember, maximum chances of cord prolapse are in transverse lie, followed by footling presentation, followed by knee presentation. Right? Now, in this case, what you are seeing? In this case, you are seeing that the legs of the baby are delivered. Now, we have put our fingers and we are trying to rotate the back. If you are seeing that with fingers, you are trying to rotate the back of the baby. Right? So, any image where you are seeing that you are trying to rotate the back of the baby, right? That means you are performing Lofset's maneuver for delivery of the shoulder. The legs of the baby are delivered and now the shoulders are being delivered by rotating the back of the baby. Now, the last part to be delivered in breech is after coming head of breech. Now, whenever you are seeing images of after coming head of breech being delivered, I want to tell all of you to first you have to see whether the back of the baby is anterior or back of the baby is posterior. For example, in this case, back of the baby is anterior, right? Whereas in this maneuver, the back of the baby is posterior. Whenever the back of the baby is posterior and the head of the baby is being delivered, no matter how much tempted you are to say that it is a Bern-Marshall technique being performed, it is not a Bern-Marshall technique, it's a Prague maneuver. There is only one maneuver for delivering the head in case of back posterior. So, if back of the baby is posterior, right, that is, it is dorso-posterior breech. Then there is only one maneuver for delivering the head of breech. There is only one maneuver for delivering the head of breech, and that is Prague's maneuver. But if the back of the baby is anterior, then in that case we have Bern-Marshall technique and we have malar flexion shoulder traction, malar flexion shoulder traction, and we can use Piper's forceps. So when the back is anterior, there are three maneuvers which can be used. One is Bern-Marshall technique, another one is malar flexion shoulder traction, and a third one is Piper's forceps. But when back is posterior, there is only one maneuver, and that is Prague's maneuver. Now, in case of Bern-Marshall technique, what do you do? In case of Bern-Marshall technique, in the image you will see that initially the baby is hanging by its own weight. Then we are holding the feet of the baby and we are taking it towards mother's abdomen. So if you see that initially the baby is hanging by its own weight and then the feet are being held and it is taken towards the mother's abdomen, that means it is Bern-Marshall technique. Now I know you are going to say, ma'am, here also we are doing the same, but over here the back is posterior, so this is not called as Bern-Marshall, this is called as Prague's maneuver. Clear to all of you? Now, in this image, what you are seeing? In this image, you are seeing that two fingers are kept on the cheek of the baby and the other hand is kept on the shoulder of the baby. So, the left hand fingers are taken inside and they are kept on the cheek of the baby. Right hand fingers are on the shoulder of the baby and we are delivering the head. This is called as malar flexion shoulder traction. Another name for malar flexion shoulder traction is Morrisseau-Smiley-Wheat maneuver. What is the most common cause of death in breech? The most common cause of death in breech is intracranial hemorrhage, right? So head of the baby may get entrapped in breech, and that is why in breech generally we prefer doing a cesarean section, right? Now, some images which are related to labor, which I want all of you to know. So, number one, images are related to lie. Now, whenever you are commenting upon the lie of the baby, please remember that uterus is generally dextro-rotated in pregnancy. So, you should first correct the dextro-rotation and then comment on lie. Very, very important. First, you should always correct dextro rotation. Kiska dextro rotation? Dextro rotation of the uterus. And then you should be commenting upon the lie. This is a very, very important takeaway message. Why? For example, this image A, I can see that the long axis of the baby and long axis of the mother are coinciding. That means it is definitely longitudinal lie. In image B, if you are not careful about dextro rotation of the uterus, you will call this as oblique lie. But beta, image B is not oblique lie. In image B, initially you have to correct the dextrorotation of the uterus. When you correct the dextrorotation of the uterus and you bring the uterus to centralized position, automatically the lie of the baby will become longitudinal lie. So image B is also longitudinal lie. Look at image C. In image C, the uterus is central, but now the baby is an oblique lie. So image C is oblique lie. Compare it with image B. In image B, the uterus itself is oblique. So I have to bring the uterus to centralized position. The moment I bring uterus to centralized position, the lie automatically becomes longitudinal. And that is why I am saying do not be in a hurry to mark the answer. First, check whether the uterus itself is in centralized position or not. Right? Then image D over here, the baby is at 90 degrees to the long axis of the mother. This is transverse lie. In transverse lie, if the mother is coming to you in antenatal period, at more than equal to 36 weeks, you should go for external cephalic version. If the patient is coming to you in latent phase of labor, you can go for external cephalic version. But if patient is coming to you in active phase of labor, you have to do a cesarean section. Right? Whether the baby is alive or whether the baby is dead, you have to go for a cesarean section. Right? Now, a very, very important image where you are getting confused always. Whenever you are getting images related to position, you are going to follow the 3 steps which I am telling you and nothing else. Follow these 3 steps only for these images. I want you to trust on me blindly. Do not apply your brains and follow the 3 steps which I am telling you. First step, what you have to do is you have to identify the occiput. How do you identify the occiput? Occiput lies directly below the posterior fontanelle, and posterior fontanelle is the triangular fontanelle. Number 2. So this over here is the triangular fontanelle, that is posterior fontanelle. This is pubic symphysis. This over here is sacral promontory. Now you have to see that whether this triangular fontanelle, it is lying close to pubic symphysis. If it is lying close to pubic symphysis, you will call it as occipito-anterior position. If it is lying close to sacral promontory, you will call it as occipito-posterior position. And if it is midway between them, you are going to call it as occipito-transverse position. Right? Then comes the third rule. If occiput is towards your left, it will be mother's right. Right? And if it is your right, it will be mother's left. Please just remember this rule and follow it. So in this particular image, you are seeing that the occiput is towards sacral promontory. So this is occipito-posterior. And because this is towards your right, it will be mother's left. So this is left occipito-posterior position. Please do not create any confusion in your mind that how is the pelvis, the pubic symphysis is facing like this, sacral promontory is facing like this. Forget about all confusions. All these confusions, just take them away from your mind. And for this one particular question, beta, just follow what I am telling you. Right? Is that clear to all of you? You are going to follow this. Why you are going to follow this is, please understand, fontanelles are never visible when you look from the top. Right? You cannot look from the top and see the fontanelles. Whenever you have to see the fontanelles, you have to look from below. And when you have to look from below, you will have to come towards the mother's foot end side and look from below. And the moment you are looking from below, you are coming in the mother's foot end side. Your left and mother's left will not be the same. Clear to all of you? Yes? Okay. Next question. Now, if I say that what is the most common occipito-posterior position? Most common occipito-posterior position is ROP position. What is the most common pelvis in which you get occipito-posterior position? In android pelvis. Now, if instead of occipito-posterior position, I ask you what is the most common pelvis in which you can get persistent occipito-posterior position or direct occipito-posterior position. The moment a prefix is added to occipito-posterior position from android pelvis, your answer changes to anthropoid pelvis. What is the best management of occipito-posterior position? Best management of occipito-posterior position is wait and watch. Now, two again very important images which are confusing. See, in case of transverse lie, if the lie of the baby is transverse and you see hand of the baby coming out, that means it is hand prolapse and it has to be managed by cesarean section. In transverse lie, hand prolapse is common, cord prolapse is common. Right, and always the management has to be cesarean section. But on the other hand, if you are seeing that the lie of the baby is longitudinal, here the lie was transverse lie. If the lie of the baby is longitudinal and along with the head, the hand of the baby is coming out, this is what is called as compound presentation. Compound presentation is not managed by cesarean section. Compound presentation is managed by vaginal delivery. This is the exact image of compound presentation which is given in Williams. What you are seeing over here, head and hand together. Whenever you are seeing head and hand together, it means image A and image B, both of them are compound presentation, and in compound presentation you allow vaginal delivery, automatically hand will go inside and head will come outside. Clear to all of you? So look at your image very, very carefully whether it is a case of transverse lie with hand coming out. Transverse lie with hand coming out means it's a case of hand prolapse and management is cesarean section. Longitudinal lie, hand and head coming down together, that is compound presentation, management is vaginal delivery, right? Next question which they asked once in FMG exam very recently is identify the type of pelvis. Now, in this case, most of you, what you do is when you answer it, you say it is a case of, it is a android pelvis. Why? Because you think the inlet is heart-shaped. Please, bacho, whenever we are talking about the boundaries of the inlet, what are the boundaries of the pelvic brim or the inlet? Boundaries of pelvic brim is pubic symphysis, then pubic crest and pubic tubercle. Then you have the iliopectineal line. Then you have sacroiliac joint. Then you have ala of the sacral bone, and then you have sacral promontory. So this is how you make the pelvic brim or the pelvic inlet. This is the shape of the pelvic brim or pelvic inlet. What some of you do is when you are looking at this image, you start drawing the pelvic brim like this. And you say, ma'am, this is heart-shaped, beta. You are not going to go to the tip of the coccyx to make the shape of the inlet. Right? Shape of the inlet has to be made along the boundaries of pelvic brim. This is how the shape of the inlet has to be made. And over here you can see the shape of the inlet is a round shape or it is slightly oval shape. That means it is gynecoid pelvis. So always draw the shape of the inlet and then decide the type of pelvis. As over here in image A, again I'm seeing it's slightly round, alright, and that is gynecoid pelvis. Over here, I am seeing that the shape of the inlet, this is what is heart-shaped. So this is android pelvis. In this case, I am seeing the shape of the inlet is a longitudinal oval. Right, that is why it is anthropoid pelvis. Here, the shape of the inlet was heart-shaped and that is why it was android pelvis. In this pelvis, it is a transverse oval. right? And this over here is platypilloid pelvis. Right? Please remember, in a gynecoid pelvis, transverse diameter is more than AP diameter at the level of inlet. In android pelvis also, transverse diameter is more than AP diameter. The only pelvis in which AP diameter is more than transverse diameter is anthropoid pelvis. In a platypilloid pelvis, transverse diameter is much more than AP diameter, and so either the shape of the inlet can be taken as transverse oval or it can be called as a flat bowl shaped inlet, right? The only pelvis in which the ischial spines are prominent is android pelvis. It has prominent ischial spines, but I am warning you, beta, you are not going to identify a pelvis based on ischial spines. You have to trace the shape of the inlet and then you have to identify the type of pelvis. Which is the most common pelvis? Gynecoid pelvis. Which is the least common pelvis? Platypilloid pelvis. What is this classification of pelvis called as? Cadwell-Molloy classification. Clear to all of you? In which pelvis is face presentation common? Face presentation is common in platypilloid pelvis. But if they ask you face to pubes delivery, face to pubes delivery is seen in which pelvis? It is seen in anthropoid pelvis. Clear? Now, coming to important images related to forceps and vacuum. Now, there are three images of forceps which you have to remember. One is a short forceps, which is an outlet forceps and is called as Wrigley's forceps, and two images are of long forceps. How are you going to decide by looking at the forceps whether it is a short forceps or whether it is a long forceps? So, in order to know whether it is a short forceps or a long forceps, I want all of you to compare the blade of the forceps with its handle and shaft. So over here, this was the blade. Over here, this is the blade, and this is the shaft and the handle. This is the blade, and this is the shaft and the handle. Now, if you see that the blade of the forceps is almost equal to the shaft and the handle, that means it is a short forceps. Right? And the only short forceps is outlet forceps, which is Wrigley's forceps. Right? So if you are seeing that the blade is equal to shaft and the handle, that means it's a short forceps, and the only short forceps which we have to know is outlet forceps, that is Wrigley's forceps, right? Now, if you are seeing that the blade is short but the shaft and the handle are long, that means they are examples of long forceps. Now, please remember, all the forceps which you are going to study, all the forceps will have English lock. All the forceps will have English lock. English lock is a lock like this. Right? So, this over here is English lock. This over here is English lock. Right? There is only one forceps which is going to have a sliding lock. Sliding lock is a button-shaped lock. The only forceps which has a sliding lock or a button-shaped lock is Kieland forceps. A Kieland forceps is a long forceps, right? It is outdated these days, and it is the only forceps which could rotate the head of the fetus. Forceps cannot rotate the head of the fetus. The only forceps which could rotate the head of the fetus was key-linked forceps. So if they show you this image, in this image I'm seeing it's a long forceps, number one. I am seeing that there is a button-shaped lock. This was a button-shaped lock. That means I am looking at the image of key-linked forceps. Now, long forceps, if you are getting a long forceps plus you are getting English lock plus you are getting an additional curve. That additional curve is perineal curve. Please understand, normally all forceps have two curves. The outer curve is pelvic curve and the inner curve is cephalic curve. Now, if you are getting a forceps where there is an additional curve and it has a English lock, right? So this is the additional curve which is called as perineal curve, right? So you are seeing an additional curve which is perineal curve. Then that means you are looking at, my drawing is bad, but that means you are looking at Piper's forceps. So look over here, all of you. In this case, you are seeing this is a long forceps, right? Why it is a long forceps? Because the blade is short in comparison to shaft and the handle. I am getting an English lock and I am getting an additional curve over here, which is perineal curve. This is a Piper's forceps. Piper's forceps is used for delivery of after coming head of breech, right? So always you have to remember only these three forceps. Short forceps hai, so it has to be Wrigley's forceps or outlet forceps. If it is image showing you long forceps means it's very easy. If you are getting a button-shaped lock, it has to be key-linked forceps. If you are getting a English lock, it has to be Piper's forceps. Even though sometimes you may not be able to actually identify the perineal curve. Even if you are unable to identify or make out that there is a perineal curve, if you see a long forceps with an English lock, it means you are looking at Piper's forceps. Clear? Okay. Now, then this is a question which came to you this time in your NEET-PG. They asked you about flexion point. What is flexion point? Flexion point is the place where you have to apply the vacuum cup. And where does this flexion point lie? The flexion point, it lies 3 centimeters anterior to posterior fontanelle. Right, so this point over here, it is lying 3 centimeters anterior to posterior fontanelle and 6 centimeters posterior to anterior fontanelle. So 6 centimeters posterior to anterior fontanelle. Another very important point is, this is where the center of the cup will lie. Now, if we are talking about the rim of the cup, this over here is the rim of the cup. Please see to it that the rim of the cup is lying directly on the posterior fontanelle. And rim of the cup is only 3 centimeters away from the anterior fontanelle. Right? Then, coming to partogram. In partogram, you have to identify two partograms. One is modified WHO partogram and the other one is labor care guide. If you get a partogram where you are seeing two parallel lines, that is alert line and action line, that means you are looking at modified WHO partogram. Please remember, in modified WHO partogram, active phase begins at 4 centimeters and so markings are going to begin from 4 centimeters. Second stage of labor is not represented in modified WHO partogram. In modified WHO partogram, there is an alert line and action line, and the time duration between alert line and action line is 4 hours. The alert line is drawn on the principle that in active phase, minimum dilatation is 1 centimeter per hour. On the other hand, if you get a partogram where there is no alert line, no action line, that means you are looking at WHO's labor care guide. In labor care guide, active phase begins at 5 centimeters, and that is why plotting or marking is going to begin from 5 centimeters. In modified WHO partogram, second stage of labor is also represented. Second stage is represented. In WHO's labor care guide, there are 7 sections, out of which section number 2 is extremely important, which is a section for supportive care. In this section, what is included? In this section is included whether the patient has taken oral fluid or not, whether there is any companion present with her or not, whether she has been given anything for pain relief or not, and number 4, in which posture she was lying, right? So these 4 things are included in section number 2, which is a new section which has come and is called as supportive care. There is no alert line, there is no action line in labor care guide. There is no alert and no action line. Clear to all of you? Okay. Then some important images related to CTG and NST. Please remember, CTG and NST are basically the same. If you are doing the same procedure with the same machine during antepartum period, it is called as NST. In NST tracing, you are going to get only fetal heart rate. There won't be any uterine contraction, right? And in this strip, you are going to, in an NST strip, you will see that there are arrow marks. These arrow marks indicate fetal movement, right? Whereas in a CTG strip, you are going to get fetal heart rate. There are 2 graphs. The above graph will be of fetal heart rate. So the graph which is on the top will be of fetal heart rate, and the graph which will be at the bottom will represent uterine contractions. So if you are getting 2 graphs, that means it is a CTG strip which has been taken during labor. Now, whenever you get a fetal heart rate in a wave-like pattern, you see that fetal heart rate is showing you a wave-like pattern. This is what is called as sinusoidal heart rate pattern, right? And this indicates fetal anemia. Fetal anemia can be seen in RH incompatibility. It can be seen in vasa previa and in twin-to-twin transfusion syndrome. Whenever you are getting sinusoidal heart rate pattern, management is intrauterine resuscitation, where you are going to give oxygen to the mother by mask. You are going to shift her into left lateral position. You are going to stop any oxytocin which you are giving, and simultaneously you are preparing her for cesarean section. So while you are preparing her for cesarean section, you are going to give her intrauterine resuscitation whenever you get sinusoidal heart rate pattern. Now, in case of CTG strip, you may get dip in fetal heart rate. Whenever you are getting a dip in fetal heart rate, which corresponds to 15 beats per minute for 15 seconds, then that is called as fetal heart rate deceleration. In a fetal heart rate deceleration, whenever you are looking at the dip, that the fetal heart rate has dipped, look at whether it is U-shaped or whether it is V-shaped. If it is V-shaped, that means it is abrupt, and that means it's a variable deceleration. So for example, see over here, why am I calling it as a CTG strip? I'm calling it as a CTG strip because I am getting 2 tracings. One is fetal heart rate tracing and the another one is uterine contraction tracing. What am I getting over here? I am getting that the fetal heart rate is dipping and the dip is V-shaped. Whenever you get V-shaped dip, that means you are looking at variable deceleration. Variable deceleration is seen in case of cord compression. So whenever the cord of the baby is getting compressed, that leads to variable deceleration. Please remember, either the dip can be V-shaped, or sometimes the decelerations are happening so quickly that you may get an image like this, right? So even if you are getting an image like this, that means it is variable deceleration. On the other hand, if you are getting U-shaped dips, so if you are getting a dip which is U-shaped, so fetal heart rate normal and then U-shaped dip, so U-shaped dip. These U-shaped dips, they can either be early deceleration or they can be late deceleration, right? This means that the deceleration has happened gradually. Now you have to see, in order to identify whether it is early or whether it is late, whenever the uterine contraction is happening, draw a line going upward from uterine contraction. And where the contraction is ending, draw a line from there. Same thing do on this graph. Draw a line from where the contraction began and draw a line from where the contraction ended. Now, if you see that the deceleration is approximately coinciding with uterine contraction, the deceleration coincides with uterine contraction, that means it is early deceleration. If you see that the dip in fetal heart rate, this is the dip in fetal heart rate, the dip in fetal heart rate is not beginning with uterine contraction and neither it is ending with uterine contraction. In this case, the dip was beginning and ending with uterine contraction. Whereas in this case, in image A, it was beginning and ending with uterine contraction. In image B, it is beginning after the contraction began and it is ending also after the contraction ends. This is what is called as late deceleration. In late deceleration, the dip in fetal heart rate begins later than the contraction and ends later than contraction. Please remember, early deceleration can be seen when the head of the baby is compressed. And head of the baby can be compressed during labor, right? So if I'm getting early decelerations, I'm not worried. But late decelerations indicate uteroplacental insufficiency. So there is something which is called as category 3 CTG findings. Category 3 CTG finding. Right? And there is something called as normal CTG finding. Normal CTG finding is called as category 1. So first of all, what are you going to get in a normal CTG? In a normal CTG, fetal heart rate will be between 110 to 160 beats per minute. Fetal heart rate variability will be present. All of you know that fetal heart rate is never fixed. It keeps on changing. And the change has to be between 5 to 25 beats per minute. Then fetal heart rate acceleration. That is increase in fetal heart rate by 15 beats per minute for 15 seconds. Now, this may be present, this may not be present in case of CTG. Fetal heart rate acceleration is important for NST. It doesn't have any significance in CTG. That is, during labor, fetal heart rate is increasing or not doesn't hold any significance, right? Then, early deceleration. Early deceleration may be present, may not be present. Even if it is present, it means that the CTG is normal. But late deceleration should be absent. Variable deceleration should be absent. These are the findings. If these findings are there, you call it as category 1 or a normal CTG. Now, what is called as category 3 CTG? Category 3 CTG is if you are getting sinusoidal heart rate pattern. Sinusoidal heart rate pattern. Number 2, if you are getting absent or decreased fetal heart rate variability. heart rate variability along with any one of the following. Along with any one of the following. What are they? Number 1, fetal heart rate bradycardia. Number 2, persistent late deceleration. And number 3, persistent variable deceleration. Whenever you get category 3 CTG findings, you have to go for cesarean section, and while you are preparing your patient for cesarean section, you have to do intrauterine resuscitation. That means you have to give oxygen by mask, you have to change the position to left lateral position, stop giving any oxytocin. Have you understood? So that is category 3 CTG findings. Now, miscellaneous images in OBS, coming to skin changes in OBS. This line over here, which is a dark brown black colored line extending from the xiphisternum to pubic symphysis, this is called as linea nigra, right? Then you can have the stretch marks of pregnancy, which are called as stria gravidarum. If they are pink in color, they are stretch marks of present pregnancy called as stria gravidarum. If they are silver in color, they are stretch marks of previous pregnancy called as stria albicans. And this over here is a cloasma. Please remember, the skin changes in pregnancy are mainly due to estrogen and melanocyte stimulating hormone. Now, this over here image is showing you Hagar sign. In Hagar sign, there is softening of the isthmus, and because isthmus is soft, when you are going to do a bimanual examination with your one hand behind the uterus parabdominally and other hand inside the vagina, it appears as if both the hand fingers are meeting with each other. This is what is called as Hagar sign, which is positive between 6 to 10 weeks of pregnancy. Softening of the cervix is what is called as Goodell sign, which becomes positive at 6 weeks of pregnancy. Over here, you are seeing bluish discoloration of cervix and vagina. This is called as Jackmere sign, or this is called as Chadwick sign. And in which week does Jackmere sign or Chadwick sign become positive? It becomes positive by 8 weeks of pregnancy. Over here, you are seeing that a stitch is being applied on the cervix, and this is what is called as cervical cerclage, right? What procedure is being done? Over here, the identification mark is that purse string sutures are being applied, and purse string sutures being applied means you are doing McDonald cerclage, right? So you are doing McDonald cerclage. Right? When can this cerclage earliest be performed? Earliest, it can be performed by 12 weeks. Best time to do it is 14 weeks. And latest, it can be performed by 24 weeks. When should the stitch be removed? Stitch should be removed at 37 weeks. Now, this over here is a Carman's cannula. This is a plastic cannula, and this cannula has a triangular opening over here like these. This is a Carman's cannula. Carman's cannula has to be attached to suction machine, and then you can go for suction evacuation, right? Suction evacuation. What is the pressure which is generated during suction evacuation? It is 600 millimeters of mercury. What size of Carman's cannula do you use? The size of the Carman's cannula, it should be equal to period of gestation. Suction evacuation, it can be done up till 16 weeks. It is the best method of MTP between 9 to 12 weeks, right? Then for suction evacuation, you need electricity. If you have to do MTP in first trimester and electricity is not available, then you have to go for manual vacuum aspiration. This over here is an MVA, manual vacuum aspiration syringe. And over here, the identification mark is that there are two pinch valves. The pressure which is generated by this syringe is 660 millimeters of mercury. If that is not given, then you are going to say 600 millimeters of mercury. What is the capacity of the syringe? The capacity of the syringe is 60 ml. Now, in front of this syringe, you will attach a Karman's cannula, and size of the Karman's cannula, it should be equal to period of gestation. Maximum manual vacuum aspiration, it can be done up till 12 weeks. Now, please remember MVA syringe, it can, so this over here is an MVA syringe. MVA syringe can be confused with menstrual regulation syringe. In menstrual regulation syringe, please remember there will be a single pinch valve, right? Plus it is a 50 ml syringe. Menstrual regulation, it was a method which was used for doing MTP up till 6 weeks, and that is why it is outdated, because these days we have a better method, and that is medical abortion using misoprost and mifepristone, which can be done up till 9 weeks. Right? Now, this over here, it is appearing as if there are lots of bruises which are seen on the uterus. This is what is called as covular uterus. Covular uterus is seen in case of concealed variety of abruptio, because blood is going to enter into the myometrium of the uterus. Remember, abruptio is also called as uterine apoplexy, and abruptio is also called as accidental hemorrhage. Right? Then, in this image, we are seeing that a pregnant patient is lying supine, and the gravid uterus is putting pressure on inferior vena cava. This is called as supine hypotension syndrome. In supine hypotension syndrome, when a patient is going to lie supine, the gravid uterus is going to press on inferior vena cava, and that is why a pregnant female is going to say that when she lies supine, she has lightheadedness and her BP goes down. The management of this condition is you have to shift the patient to left lateral position. This over here is an image which is showing you a vulval hematoma. Vulval hematoma is going to involve pudendal artery, right? And patient is going to have pain after delivery, and there will be difficulty in passing urine. If there will be active bleeding going on, then your patient may also go into shock. Now, these are two images which are showing, one of them is uterine inversion, one of them is prolapse. I want all of you to understand, suppose this is the support of the uterus, and this over here is a normal uterus, and this over here is the os, right? This is the internal os. Now, what happens in case of prolapse? In case of prolapse, the entire uterus is going to come out like this only. Right, so there is downward displacement of the uterus. Whereas in case of uterine inversion, it is the fundus of the uterus which inverts and comes out. This over here is uterine inversion. Now, whenever you are given image and you are confused whether you are looking at the image of inversion or whether you are looking at the image of prolapse, see if internal os is visible or not. If internal os is visible, that means you are looking at the image of prolapse. If internal os is not visible, that means you are looking at image of uterine inversion. So image A, internal os is not visible. It is a case of inversion of the uterus. Image B में internal os is visible, and that is why it is an image of prolapse. Clear to all of you? How does a patient of uterine inversion present to you? A patient of uterine inversion will present to you. The question will say that a patient goes into immediate shock after delivery. The moment your question says patient goes into immediate shock after delivery, it means they are talking about uterine inversion. This over here is an image of episiotomy scissors. Please see that episiotomy scissor has an angle, right? It will always have an angle, and it is not going to be a sharp end. It will have curved ends, right? Then you have to know images related to perineal tear. First degree perineal tear means that only the vaginal mucosa is involved. If you see that only vaginal mucosa is torn, that means it's a first degree perineal tear. If you see that the muscles are also torn, if the muscles are also torn in the image, that means you are looking at second degree perineal tear. If you see that the anal sphincter is torn, that means it's a third degree perineal tear, and along with anal sphincter, if your image shows rectum is also torn, that is fourth degree perineal tear. In third degree perineal tear, we have 3A, 3B, 3C. 3A means less than 50% of external anal sphincter torn. 3B means more than equal to 50% of external anal sphincter torn. And 3C means external anal sphincter plus internal anal sphincter torn. Please remember, third degree and fourth degree perineal tears, they are called as complete perineal tears, and they have to be repaired in OT under general anesthesia. But first degree and second degree perineal tear are comparable to episiotomies, and they can be repaired in the labor room under local anesthesia. Right? Again, this was your this year's NEET PYQ. So with this, we come to an end of all the images in OBS which I want you to know. Now let's see all the important images in gynae and quickly revise them. So first, I'm going to let you know about all the important images which are related to the menstrual cycle and the different phases of menstrual cycle. Now, all of you know that vagina is lined by stratified squamous epithelium, and in vagina there are three types of cells. There are the superficial cells, intermediate cells, and parabasal cells. Now, superficial cells are pink colored cells. So, whenever you are getting a smear with pink colored cells, these are eosinophilic cells and they have a pycnotic nuclei. These superficial cells, they are seen whenever estrogen is predominant. And when is estrogen predominant? Estrogen is predominant in first half of menstrual cycle. So whenever you are going to take a look at the vaginal epithelium smear in the first half of menstrual cycle, then the cells which are going to predominate will be the superficial cells. Then you can get intermediate cells. Intermediate cells are these cells, the cells which are blue in color. They are basophilic and they have small nucleus. They are seen whenever progesterone is predominant. Please remember, progesterone is predominant in second half of menstrual cycle, right? Or in case of pregnancy. The other name for intermediate cells is navicular cells. And a third type of cells which you get are again these blue colored cells, but these are now called as parabasal cells. These blue colored cells, they have a big nuclei, as you can see. They have indistinct or blurred margins, and they are seen whenever there is no hormonal predominance. And will there be no hormonal predominance? There will be no hormonal predominance during menopause, after menopause, then before puberty, and after delivery. There is something which is called as maturation index. In maturation index, we are going to count 100 vaginal epithelial cells, and out of those 100 cells, we are going to report that how many of them are parabasal. The first number which you write is the number of parabasal cells, then the number of intermediate cells, and then the number of superficial cells, right? So, superficial cells. For example, if you are getting maturation index as 100 by 0 by 0, that means all cells are parabasal, and that means this is a maturation index which you can get in a menopausal female, or if you are getting maturation index as 0/40/60. This means that 60% cells which were counted were superficial cells, 40% were intermediate cells, none of them are parabasal cells. So which hormone is predominant? Estrogen is predominant. That means this is a type of maturation index which you can get in first half of the cycle. If you are getting 0/70/30, this means which cells are predominating? Intermediate cells are predominating. And when do intermediate cells predominate? Whenever progesterone predominates. So this is something which you can get in second half of the cycle or in pregnancy. Please understand, you don't have to mug up the maturation index. Instead of 0/40/60, it could have been 0/30/70, then also it would have meant the same. It could have been 0/25/75, then also it would have meant the same. So you don't have to mug up the maturation index. You simply have to understand the interpretation of maturation index. Clear to all of you? Right. Next question which they sometimes ask is that for hormonal study, sample should be taken from which wall of vagina? So please remember, for hormonal study, sample should be taken from the lateral wall of vagina. Now this is the ultrasound image which is seen of different phases in menstrual cycle. So how does endometrium appear in different phases of menstrual cycle? If you are seeing, see this over here is the uterus, this is the myometrium, and this thin white line which you are getting. So the thin white line which you see over here, this is endometrium. Whenever endometrium is appearing in the form of thin white line, this means this ultrasound was done in proliferative phase and it was done in early proliferative phase. Right? Now, if you are seeing endometrium, so this over here is myometrium, uterus, and this is endometrium, and now endometrium is appearing in the form of 3 layers. Can you see? There are 3 layers of endometrium, 1, 2 and 3. So whenever you are getting a trilaminar appearance of endometrium, this kind of appearance you get in late proliferative phase. For sometimes late proliferative phase is not given in the options, then you have to say that this is the kind of ultrasound appearance which you get at the time of ovulation. Now at the time of secretory phase, progesterone will come, and when progesterone will come, now this endometrium, the 3 layers will disappear. Now you are going to get thick endometrium with posterior acoustic enhancement. So if you are getting endometrium like this, it's a thick endometrium and you are getting a posterior acoustic enhancement. This is the kind of ultrasound appearance of the endometrium which you get in secretory phase. Then you should also know, in different phases of the cycle, how does endometrial biopsy appearance change? So if on endometrial biopsy you are getting simple tubular glands, do you see that the glands are very simple over here? They are not coiled, very simple glands. So if you are getting simple tubular glands, and do you notice that over here the nuclei are at different levels? Because the nuclei are at different levels, it appears as if there is stratification. There is no stratification. This is what is pseudo stratification. So if you are getting simple tubular glands on endometrial biopsy and there is pseudo stratification, that means nuclei are at different levels. This means this endometrial biopsy was taken in proliferative phase. Now, as we are going to move towards ovulation and towards early secretory phase, what we are going to see is that the glands will start coiling, and now there is going to be a subnuclear vacuolation. What do you mean by subnuclear vacuolation? I want all of you to concentrate on these purple colored nuclei. You pick up any purple colored nuclei and below that you will see a white space. Take any purple colored nuclei, look at any purple colored nuclei and you are going to see a white space. This is what is called as subnuclear vacuolation. Please remember, subnuclear vacuolation is the earliest sign of ovulation on endometrial biopsy, but it appears by day 17 of the cycle. So if they show you an image like this where the glands have started coiling and you are getting subnuclear vacuolation, and they ask you in which phase of the menstrual cycle was this endometrial biopsy taken, Don't say it as the ovulatory phase. The best answer to this will be early secretory phase, because subnuclear vacillation appears by day 17 of the cycle. So the best answer is early secretory phase. If early secretory phase is not given in the options, then you are going to say that at the time of ovulation. Now, as we move towards late secretory phase, the glands are going to become hypercoiled. So there will be hypercoiling of the glands. As you can see over here, the glands have become hypercoiled, right? And this is what is called as sawtooth appearance of the glands or corkscrew appearance of the glands. And inside the glands, you are seeing this white colored fluid which is filled, white colored material which is filled, that is, glands are filled with secretions. So if you are seeing hypercoiled glands and if you are seeing that the glands are filled with secretions, that means this is an endometrial biopsy which is taken in the late secretory phase. With this, let us do certain images which you need to know on endometriosis, PCOS, fibroid and adenomyosis. Now, this image over here is showing you a chocolate cyst on laparoscopy. Chocolate cyst is also called as endometrioma, right? And endometrioma, please remember, the management of endometrioma always has to be surgical management. But if your patient desires fertility, if she desires pregnancy, then I don't have to operate on a chocolate cyst immediately. Chocolate cyst, if it is asymptomatic and it is less than 5 centimeters, it requires conservative management. If it is more than equal to 5 centimeters, you have to go for laparoscopic cystectomy, right? This image has been asked many times in exam, and please look at the chocolate cyst very, very carefully. Once I'm going to do ultrasound images with you, then I will also show you how a chocolate cyst appears on ultrasound. Then, this over here, these are the brownish black cystic areas which you see on the peritoneum. This is what is called as gunshot appearance on laparoscopy. Gunshot appearance on laparoscopy indicates old lesions. Please understand, endometriosis is present of endometrium outside the uterus. So whenever endometrium is present outside the uterus, it is still hormonally active. So if this endometrium was present on peritoneum, it will bleed, and after bleeding, there is going to be, the blood is going to remain there and it is going to turn bluish blackish in color, and that is what gives appearance of this gunshot appearance, right? A very, very important thing which I want all of you to know, in case of endometriosis, a patient's main complaint to you is pain, and the pain with which she comes most commonly is secondary dysmenorrhea, followed by chronic pelvic pain and dyspareunia. Right now, whenever in your question, this is a thumb rule which I want all of you to remember. Whenever in your question you are getting dysmenorrhea and dyspareunia together, it means it is endometriosis. In no other condition are you going to get dysmenorrhea and dyspareunia together, right? Along with pain, patient may complain of infertility and adnexal mass. This adnexal mass is a bilateral adnexal mass, and actually this adnexal mass is nothing but a chocolate cyst. Now, in case of endometriosis, on per vaginal examination, there are typical findings which you get, and that is you get a fixed retroverted uterus. What do you mean by a fixed retroverted uterus? Fixed retroverted uterus means that even though you try to manually correct the retroversion will not be corrected manually. You will not be able to correct the retroverted uterus manually. And there will be bilateral adnexal mass, and there is going to be bilateral tenderness which will be present, right? So these are the pervaginal findings which you are going to get in case of endometriosis. On laparoscopy, please remember the investigation of choice of endometriosis is laparoscopy. And this is what you get on laparoscopy when you look at endometriosis. In case of endometriosis, you can get a chocolate cyst. You can get bluish black colored cystic areas present on the peritoneum which represent old lesions, and they are called as gunshot appearance. Then you can get red colored spots, red colored lesions like this which indicate new lesions, right? So these are called as red flame lesions. Red flame lesions. Then on laparoscopy in endometriosis, you can get peritoneal defects. These peritoneal defects are called as Allen-Masters syndrome, right? So these were the laparoscopic images which you can get in case of endometriosis. Now coming to a fibroid. How does a fibroid appear? So the cut surface of a fibroid, please see, it is always white in color. It shows you a whorled appearance or an uneven appearance. It arises from a broad base, and always a fibroid is surrounded by a pseudocapsule. Please remember, the blood vessels which supply the fibroid are present in the pseudocapsule. That is why the most vascular part of the fibroid is the pseudocapsule or the periphery, and the least vascular part is the center of the fibroid. What is the investigation of choice in case of fibroid? The investigation of choice in case of fibroid is TVS. Please compare the gross appearance of a fibroid to gross appearance of a polyp. Now, a polyp is a mucosal outgrowth. It is fleshy red in color. As you can see over here, it's fleshy red in color. It has a very smooth surface and it always arises from a narrow base. A polyp is supplied by a single blood vessel which comes up till the center, and this forms the basis of the feeder vessel sign which you get on Doppler ultrasound. The investigation of choice in case of polyp is hysteroscopy. Right? Then, this is how on hysteroscopy a fibroid and a polyp are going to appear. Whenever on hysteroscopy you are seeing that the growth, whatever growth you are getting inside the uterus is pale in color, it has broad base and it has got irregular surface, right? Plus it has got surface blood vessels. That means you are looking at a fibroid. If you are seeing a growth which is beefy red in color, which arising from a narrow base, it has no surface blood vessels and it is very, very smooth, that means you are looking at a polyp. So you should know how to differentiate between polyp and fibroid, not only on gross appearances but also on hysteroscopic appearance. Then this over here is a gross specimen of adenomyosis. What is adenomyosis? Adenomyosis is a condition where endometrium is present inside the myometrium. Because endometrium is present inside the myometrium undergoes hypertrophy, and this leads to symmetrical enlargement of the uterus. So in case of adenomyosis, you get a smooth globular appearance of the uterus. Whenever you are getting a smooth globular symmetrically enlarged uterus, it means you are looking at adenomyosis. Now please remember, this endometrium which is present inside the myometrium is hormonally active, and that is why you are going to get multiple hemorrhages, right? Now in adenomyosis, a very, very important thing to remember is that the uterus is tender in adenomyosis, and this is what is called as Halban sign, number 1. Number 2, although uterus is symmetrically enlarged, uterus is never more than 12 weeks pregnant uterus size, right? And number 3, the investigation of choice in case of adenomyosis is MRI. This is in contrast to fibroid. In case of fibroid, because fibroid is going to arise from one side of the uterus. So uterus is never symmetrically enlarged, uterus is asymmetrically enlarged. The size of the uterus may reach up till 20 weeks pregnant uterus size. And in case of fibroid, uterus is never tender. Whereas in case of adenomyosis, uterine tenderness is present, which is called as Halban sign positive. Why do you think tenderness is present? This is because endometrium is hormonally active, so there will be bleeding every month. There is going to be bleeding inside the myometrium, and for that blood, so that blood dissolves, inflammatory cells are going to come so that the blood dissolves. Because inflammatory cells are going to come, that is why it is going to lead to inflammation and there will be tenderness. So in adenomyosis, uterus is tender, right? So these were the important images of gross, specimens of fibroid, polyp and adenomyosis. Now some important ultrasound images which I want you to see. See, this over here is a cyst. Normally, a cyst appears jet black in color. This is an ovarian cyst, but this ovarian cyst is not appearing jet black in color. This ovarian cyst is something which has got homogeneous internal echoes. What do you say to this appearance? You say that there is an ovarian cyst with homogeneous internal echoes or a ground glass appearance. This is how a chocolate cyst appears on ultrasound. So this is a typical description of a chocolate cyst on ultrasound, that you are going to get a ground glass appearance or you are going to get a cyst with homogeneous internal echoes. Right? Now my question to you is, in case of endometriosis, the most common complaint of a female is secondary dysmenorrhea. So if a female comes to you or a woman comes to you with complaint of secondary dysmenorrhea, what is the next step? All of you know the investigation of choice for endometriosis is laparoscopy. Now, even though I am suspecting endometriosis, am I going to do a laparoscopy immediately when a female is coming to me with secondary dysmenorrhea? No. Next step is ultrasound, TVS. Why am I doing TVS? I am doing TVS to rule out other causes of secondary dysmenorrhea. I may not see a chocolate cyst on ultrasound. But if I am not seeing a chocolate cyst on ultrasound, that does not mean that my patient cannot have endometriosis. Even though the chocolate cyst may not be visible on ultrasound, still my patient can have endometriosis. As I told you, what is the investigation of choice for endometriosis? It is laparoscopy, and the gold standard is histopathological examination. In case of adenomyosis also, beta, remember that the gold standard is histopathological examination. In adenomyosis, the management is hysterectomy. After hysterectomy, you send the sample for histopathological examination. Right? What you are seeing over here? You are seeing over here that there is a growth which has arisen from the uterus and it is coming inside the cavity. The texture of the growth and the texture of myometrium are the same. This growth is arising from a broad base, and that is why most probably I am looking at ultrasound of fibroid. Please remember, in case of fibroid, the investigation of choice is ultrasound or TVS. In a submucous fibroid, the investigation of choice is saline infusion sonography. What is saline infusion sonography? Please remember that in case of uterus, the uterine cavity is a potential cavity. What do you mean by that? That anterior and the posterior wall of the uterus are opposed to each other. Only if something is present inside the cavity, then the cavity distends, right? So if I want to look inside the uterus for a submucous fibroid, I am going to make the uterine cavity distend with normal saline, right? So the anterior and the posterior wall will separate, and plus normal saline will appear jet black in color. So against that jet black color, the fibroid will be very easily visible, right? So that is what is saline infusion sonography. Now, a submucous fibroid can be type 0 or type 1 or type 2. What is a type 0 submucous fibroid? A submucous fibroid which is found completely inside the uterine cavity is a type 0 submucous fibroid. What is a type 1 submucous fibroid? A submucous fibroid which is more than 50% inside the uterine cavity, less than 50% inside the myometrium. And what is type 2? It is opposite of this. If a fibroid is less than 50% inside the cavity and more than 50% inside myometrium, that is type 2. This is FIGO classification. Now, type 0 and type 1 submucous fibroid, they can be removed hysteroscopically. They are removed hysteroscopically. Whereas type 2 submucous fibroid has to be removed laparoscopically. This is the difference. Clear to all of you? Next image over here. In this image, I am seeing that there is a growth over here which is being supplied by a single blood vessel. When I switched on the Doppler, I am seeing a single blood vessel which is going up till the center of the growth. This is what is feeder vessel sign, and this feeder vessel sign is seen in polyp. Which kind of polyp? It is seen in endometrial polyp. Very, very important question, and that is feeder vessel sign. I am erasing so that you can appreciate the blood vessel which is going up till the center of the polyp. Right? Now, Please remember, in case of polyp, the investigation of choice was hysteroscopy, and in case of polyp, polyp can be endometrial polyp. Endometrial polyp, the management is hysteroscopic polypectomy. Hysteroscopic polypectomy. But a polyp can also be endocervical. Now, if it is endocervical polyp, I don't require a hysteroscope to remove it. Endocervical polyp is removed with the help of polypectomy hook. I will still do polypectomy, but I'm going to do it with the polypectomy hook. In this ultrasound, what are you seeing? In this ultrasound, you are seeing alternate dark and light band. Dark band, then light band. Dark band, light band, dark band, light band. These alternate dark and light band, this is what is called as Venetian blind appearance. And this Venetian blind appearance is something which you see in case of adenomyosis of the uterus, right? In this case, what I'm seeing? In this case, I'm seeing that this over here is the myometrium. Although myometrium is appearing hypertrophy to me, along with that, what I'm seeing is a black colored area inside the myometrium. Black colored area means that there is fluid which is filled inside it. And what fluid is filled inside it? There is blood. How did blood come inside the myometrium? Because endometrium is present inside the myometrium, right? And this is what is called as myometrial cyst. Please remember, myometrial cyst is the most specific sign of adenomyosis on ultrasound, right? Now, this over here, what are you seeing? In this case, you are seeing that this over here is the ovary, and around the periphery of the ovary, follicles are present in a necklace pattern. So this is necklace pattern, right? And this is ultrasound of polycystic ovaries. Polycystic ovaries means that there have to be more than equal to 12 follicles, 2 to 9 millimeters in size in one or both the ovaries. Or if the size of the ovary is more than equal to 10 cc, then that is also an ultrasound criteria for diagnosing PCOS as per Rotterdam criteria. So in Rotterdam criteria, there are 3 things which are there listed by Rotterdam, out of which 2 should be present. What are those 3? Number 1, increase in androgen levels, which should either be manifested clinically or it should be manifested biochemically in the form of increased testosterone. Number 2, ovulatory dysfunction manifested in the form of oligomenorrhea or amenorrhea. How do you define oligomenorrhea? If a female is having less than 9 cycles in a year, that means it is oligomenorrhea. And number 3 is polycystic appearance of the ovaries on ultrasound. That means more than equal to 12 follicles, which are 2 to 9 millimeters in size, right, in one or both the ovaries, or if volume of the ovaries more than 10 cc. That is what is included in Rotterdam criteria. Out of these 3, Rotterdam says any 2 should be present to say that your patient has PCOS. Please remember, in Rotterdam criteria, there are more. Rotterdam criteria says that the number of follicles should be more than equal to 12, whereas European and American societies have recently updated their criteria, and they are saying that it has to be called as polycystic ovaries. The number of follicles should be more than equal to 20. Nevertheless, in Rotterdam, still it is more than equal to 12. Now, the follicles are usually arranged around the periphery of the ovary in necklace pattern, but Rotterdam criteria does not say, it does not include necklace pattern. Rotterdam says that you should get more than equal to 12 follicles, even if those follicles are present in the center like this. Still, you are going to include it in Rotterdam criteria. Rotterdam is not saying that they have to be present in a necklace pattern. Right, so I want all of you to see this ultrasound. This is extremely important ultrasound. This ultrasound should be compared to this ultrasound. If you are getting follicles which are more in number and they are big in size, then that is not PCOS. Then either that is a case of ovarian hyperstimulation syndrome, or it is a case of theca lutein cyst in the ovary. Right, please remember, If this ultrasound comes to you and they say that patient has infertility and there is history of IVF, that means you are looking at ovarian hyperstimulation syndrome ultrasound. But if the same ultrasound image is shown to you and they say that there is a pregnant female who has come to you with bleeding in first trimester and she has high HCG levels, that means you are looking at theca lutein cysts of the ovary, which are seen in case of molar pregnancy, right? So same image you are going to get. Depending upon what description is giving, you are going to decide your diagnosis. Please remember, ovarian hyperstimulation syndrome, that's an iatrogenic complication, most commonly the drug which has got maximum risk and that leads to development of OHSS is HMG. Lesser common is clomiphene citrate, and letrozole never leads to OHSS. What is the triggering factor for OHSS? The triggering factor is injection HCG. What is early OHSS? Early OHSS is when the symptoms of OHSS, they develop within 9 days of injection HCG. Late OHSS is when symptoms of OHSS develop more than equal to 9 days after injection HCG, and this is due to the endogenous HCG which is produced by a pregnant female. This is not because of injection HCG, right? So this is what you have to know about this ultrasound, that is ovarian hyperstimulation syndrome. Now, ultrasound images of PID, very, very important, because recently in NEET they had given one of these images. Now, see, the NACO says, National AIDS Control Organization says that in case of PID, when you are doing syndromic management, no ultrasound is required. Simply based on history of the patient plus based on examination findings, you have to give kit number 6 to the patient. What are the symptoms with which the patient is going to come to you? Now, in case of PID, NACO says that if your patient is coming to you with lower abdominal pain and plus there is any one of the following. What is that any one of the following? That any one of the following should be uterine tenderness or cervical tenderness or adnexal tenderness. Then no investigations are needed. Right? If you want to rule out ectopic pregnancy, because in ectopic pregnancy also you get pain in lower abdomen and you get cervical movement tenderness, you can do a urine pregnancy test, and if urine pregnancy test comes out to be negative, then you have to give kit number 6 to your patient. Kit number 6 is a yellow colored kit, right? And to the partner you have to give kit number 1. This is what NACO is saying, that based on minimum investigations, you have to start treatment for PID. But if you are going by the CDC, that you have to do investigations, then the investigations which you can get done in a patient of PID are endometrial biopsy. When you do endometrial biopsy in a patient of PID, you get endometritis. Number 2, you can go for ultrasound. On ultrasound in PID, you can get 3 signs. Number 1 is bead on string appearance. Number 2, you can get cog wheel sign. And number 3, you can get waist sign. Right? Then you can go for laparoscopy. Please remember, when you do laparoscopy in case of PID, you will see pus coming out from the fimbrial end of the tube. You can take that pus and send it for culture and sensitivity. You can do scoring for conception. The scoring for conception in case of PID is Bohr-Meisel score. You can do the staging of PID. What is the staging of PID called as? Ganswell staging. Right? Now I want to show you the ultrasound signs. Number 1 ultrasound sign is, you can see that over here is the tube, and on the tube it appears as if beads are present. This is called as beads of string appearance. So in case of PID on ultrasound, you can get a beads of string appearance. or you can get a cogwheel appearance like this. This is an ultrasound which had come this time in your NEET-PG. So you can get a cogwheel appearance, or whenever you have to depict a girl, how do you make? You make a thin waist of a girl like this. Similarly, in case of PID, in fallopian tube, you can get thin waist like this, and this is what is called as waist sign. So these are 3 signs which you can get on ultrasound in case of PID. Coming to important images which you have to know on HSG, that is hysterosalpingography. Before I go to what all you can come to know on HSG in what all things can be identified or diagnosed by HSG, some important points which I want you to revise with me on HSG. HSG, when do you do it? HSG is done between day 7 to day 10 of the cycle. The dye which you use in HSG is water-soluble iodinated dye, urographin. Right, the instrument which you use in HSG to pass the dye is a Leach-Wilkinson cannula. A Leach-Wilkinson cannula will have a proximal funnel-shaped end with serrations like this. Right, this is how a Leach-Wilkinson cannula looks like. What are the contraindications for HSG? Contraindications for HSG are pregnancy. Then if your patient has active genital TB and your patient has active PID. Why in case of active genital TB and PID I cannot do HSG? This is because when the dye is going to come out from the fimbrial end of the tube, it can lead to spread of infections. What all things can be detected by HSG? Please remember, HSG is not done to diagnose Mullerian malformations. Mullerian malformations are a coincidental finding on HSG. Number 2. See, in patients of genital TB, they come to you with complaint of infertility, and whenever a couple is coming to you with complaint of infertility, there are 3 basic investigations which all of us have to do. Number 1, I have to get a semen analysis done. Number 2, I have to do a test for ovulation, which is example serum progesterone levels. And number 3, I have to see whether the tubes are patent or not, and that is why I will have to do HSG. Now, genital TB ki patient mein most common complaint is infertility, and just now I said that in genital TB I don't have to do HSG. So how am I going to know whether in a genital TB patients the tubes are patent or the tubes are blocked? So what we do is we first start the patient on ATT. We put the patient on ATT and then we do HSG. HSG definitely has to be done, but it should be done only after putting your patient on ATT. Now, when you do HSG in a patient on genital TB, there are certain typical appearances which you are going to get, and these typical appearances are, number 1, beaded appearance of the tube. So please be very careful. If your question is saying that a beaded appearance is seen on ultrasound in the tube, then it is an ultrasound of PID. If your question says necklace pattern is seen on ultrasound in the ovary, then the diagnosis is PCOS. If your question says beaded appearance is seen on HSG, right, in the tubes, then the answer is genital TB. Then you can get gallstick appearance, cotton wool appearance, lead pipe appearance, bilateral cornwall block, tobacco pouch-like appearance, and Asherman syndrome. So look over here. This is how a beaded appearance of the tube looks like on HSG, and whenever you are getting beaded appearance of the tube on HSG, then that means it is genital TB. Then you can get a lead pipe appearance. You can see the tubes are standing straight like this. So this is what is lead pipe appearance of the tube. Then you can get gallstick appearance of the tube, or you can get cotton wool appearance of the tube on HSG. Then the other important thing about HSG is that HSG is the investigation of choice for tubal patency, and you can diagnose tubal blocks with the help of HSG. Now, please understand that always the investigation of choice for tubal patency is HSG, but the gold standard investigation is laparoscopic chromoperturbation. What do you mean by laparoscopic chromoperturbation? Laparoscopic chromoperturbation means that I am going to put a laparoscope and then per vaginally I will put a dye, and with my own eyes I will see whether the dye is coming out or not. This is laparoscopic chromoperturbation. So please, whenever your question says that there is a bilateral tubal block on HSG, what is the next step? Next step is you have to do the gold standard investigation, and that is you have to do laparoscopic chromoperturbation, right? This is in all cases. Whenever you are getting a block on HSG, go for laparoscopic chromoperturbation. Now, when we are talking about blocks on HSG, these are the two typical images which you can get. See, in this over here, this is the shadow of Leach-Wilkinson cannula. I am seeing that the dye has gone inside the uterus. Dye has gone up till the cornua or the angle of the uterus, and then the dye has not gone any further. This is an image which is showing you bilateral cornual block. Now, the question which they ask you is that what is the most common cause of bilateral cornual block? Please remember, HSG is a painful procedure. So, when you put a dye, then the tubes undergo spasm, and that is why the most common cause of bilateral cornual block is physiological spasm. Either this entire term will be written or only physiological will be written. What is the most common pathological cause of bilateral cornual block? That is genital TB. Now, as I told you, whenever you get a block on HSG, a bilateral block on HSG, it should always be followed by laparoscopic chromoperturbation. So, if they show you an image of bilateral cornual block, HSG of bilateral cornual block, and they ask you next step has to be laparoscopic chromoperturbation. But in case of bilateral cornual block, you also have to go for hysteroscopy. So, in bilateral cornual block, the next step is laparoscopy plus hysteroscopy. Are you understanding? It's not just laparoscopy. A second kind of block can be a block like this, where you are seeing that the dye has gone inside the fallopian tube and then it has not come out, and the distal end of the fallopian tubes are also swollen. So, this is what is bilateral distal block, plus you are getting a hydrosalpinx. Again, if they show you this image and they ask you what is the next step, what is the next step? Next step has to be laparoscopic chromoperturbation. Then another use of HSG is that on HSG you can get filling defects. Now, whenever you are getting filling defects on HSG, then there are only two possibilities. One possibility is that it can be an HSG of Asherman syndrome, or a second possibility is that it can be an HSG showing you a fibroid or a polyp, right? In case of Asherman syndrome, when you are going to do HSG, because of the additions, there will be multiple filling defects. These filling defects will have irregular outline, and this is what is called as moth-eaten appearance. So, do you see over here, there are multiple filling defects, and these filling defects have got irregular outline. But please remember, a fibroid or a polyp can also lead to a filling defect. In case of fibroid or polyp, when I am going to pass the dye is going to go everywhere except where the fibroid or the polyp was present. So, whenever a fibroid or a polyp is present, again I am going to get a filling defect, which generally is a single defect, and it is smooth filling defect. Do you see over here? The filling defect is very, very smooth and it has a regular outline. So, if you are getting a smooth filling defect with regular outline, that means it is a HSG showing you a polyp or a fibroid. Okay, Bacho, now the set of images which we have to do, they are all related to Mullerian malformations. In Mullerian malformations, the first image which you should be aware of is the image of uniconvate uterus. Please understand that in uniconvate uterus, this is the only condition where you get a single fallopian tube. So, whenever you are getting a single fallopian tube and you are getting a banana-shaped uterus, right, then it means that it is a uniconvate uterus. Uniconvate uterus means that only one side Mullerian duct is present, and that is why there is only one fallopian tube. So, any HSG image where you are getting a single fallopian tube and a banana-shaped uterus, it means that HSG belongs to uniconvate uterus. Then number 2 comes uterus diadelphus. What do you mean by uterus diadelphus? Uterus diadelphys means that both Mullerian ducts are present. Either they are failing to fuse, they don't fuse, and if they won't fuse, what is going to happen? There will be 2 fallopian tubes, 2 uterus, 2 cervix, and there will be 2 vaginas. Or it could be that if they have fused, then the fusion has happened only in vagina. So please understand, in a diadelphic uterus, they can be single vagina or they can be 2 vaginas. The distinguishing feature of diadelphic uterus is that there are always 2 cervix. Always in a diadelphic uterus, there are 2 cervix, and because there are 2 cervix, understand from here, because there are 2 cervix, that is why I will require 2 Leach-Wilkinson cannulas. So 1 Leach-Wilkinson cannula, 2nd Leach-Wilkinson cannula. So anytime you are getting an HSG where you are seeing 2 Leach-Wilkinson cannulas being used, it means it is an HSG belonging to diadelphic uterus. Now they can show you these images also. It's not necessary that they give you only HSG images. They can show you drawings also. In drawings, you should count the number of fallopian tubes. There are 2 fallopian tubes, so obviously it cannot be uniconvate uterus. Then I'm seeing that there are 2 halves of the uterus. We are seeing that there are 2 cervix. Now the moment your question says there are 2 cervix, please understand and highlight this point, that whenever there are 2 cervix, it means it has to be a diadelphic uterus. In this case, there is a single vagina. Vagina can be single, vagina can be 2. But diadelphic uterus is always characterized by 2 cervix, right? Then next comes your biconvate uterus. Biconvate uterus means that both side Mullerian ducts, they are present. They have started fusing, but they have fused only in cervix and vagina. The uterus is not fused. So over here what we see is that there are 2 fallopian tubes. Like you can see, I've written over here, there are 2 fallopian tubes, right? Then there are 2 uterus, right? So there are 2 uterus. There is a single cervix and single vagina, right? So in case of biconvate uterus, always you will get a single cervix. A very important point about biconvate uterus is you should always look at the top of the uterus. In a biconvate uterus, you are always going to get that the fundus of the uterus is divided. Why we are stressing on this point is because the same kind of situation you get in a septate uterus. In a septate uterus, again you get 2 fallopian tubes, you get 2 parts of the uterus, you get single cervix and single vagina. The difference is, in case of septate uterus, the upper part of the uterus is intact, right? The shape of the uterus is intact. It is not divided. But in case of biconvate uterus, the fundus of the uterus is divided. This means that in order to differentiate between a biconvate uterus and septate uterus, I should be able to look at the fundus of the uterus. And that is why HSG is not the investigation of choice in Mullerian malformations, because with the help of HSG, you cannot look at the fundus of the uterus. That is why investigation of choice in case of Mullerian malformations is 3D ultrasound. And what is the gold standard? Gold standard is MRI, right? And what is the last resort? Last resort, if you are unable to find out which Mullerian malformation it is, you should do both hysteroscopy plus laparoscopy together. Laparoscopy will show you the top of the uterus and hysteroscopy will show you the inside of the uterus. Now on HSG, although it is very difficult to differentiate between biconvate and septate uterus, but in your exams you are asked this question. So what you have to see is, whenever you get an HSG, first of all, look at the number of fallopian tubes. How many fallopian tubes you are getting? 2. That means it cannot be a uniconvate uterus. How many Leach-Wilkinson cannulas I am getting? I am getting a single Leach-Wilkinson cannula. That means it cannot be a diadelphous uterus. Now I have to, this means that either this is a biconvate uterus or a septate uterus. Now look at the angle between the uterine horns. If the angle between the uterine horns, if it is obtuse, right, and the distance between the horns is more than equal to 4 centimeters, that means you are looking at an HSG of a biconvate uterus. On the other hand, look over here. In this HSG, again, what I'm getting, in this HSG, again, I'm getting that there are 2 fallopian tubes. Again, I'm getting a single Leach-Wilkinson cannula, so it cannot be a uniconvate uterus, it cannot be a diadelphic uterus. Now, again, between the 2 uterine horns, look at the angle. The angle between the 2 uterine horns is acute, right? And the distance between them is less than 4 centimeters. That is why this is an HSG belonging to a septate uterus. Is that clear to all of you? Okay, now coming to some important images which you have to remember with respect to cancer. Now these images are extremely important. I know all of you know that this over here is Ayer's spatula, and this is an endocervical brush. Both of them are used to take sample for pap smear, and Ayer's spatula is used to take sample from the transformation zone which lies near the level of external os, and endocervical brush is used to take sample from the endocervix. Both of these instruments, they are used for taking conventional pap smear, right? So whatever sample is coming from Ayer's spatula, I'm going to put it on one slide, and on the same slide I'm going to roll on whatever sample I'm getting from the endocervix. Do not air dry the slide, right? And the fixator which is used in case of pap smear is 95% ethyl alcohol plus minus 5% ether. What is the best time to do pap smear? The best time to do pap smear is in the peri-ovulatory phase. Is there any absolute contraindication for pap smear? No. But a relative contraindication is bleeding. Now, this instrument over here which you are seeing, this instrument is a cervical brush. So this over here is a cervical brush. In a cervical brush, beta, you are getting big bristles in the center and you are getting smaller bristles towards the sides. The big bristles are going to reach up till the level of endocervix and they are going to bring sample from endocervix, and the smaller bristles which are towards the side, they are going to bring you sample from the transformation zone which lies near the level of external os. This cervical brush or cervical broom is used in liquid-based cytology. In liquid-based cytology, please remember the advantage of liquid-based cytology is number one, the pickup rate of liquid-based cytology is better, number one. Number two, in liquid-based cytology, bleeding is not a contraindication. And number three, you do not require a separate sample for HPV DNA testing in case of liquid-based cytology. So there are three advantages of liquid-based cytology. Number one, it has a better pickup rate. Number two, bleeding is not a contraindication. And number three, you don't require a separate sample for HPV DNA testing. Now these instruments over here, this is a tandem and an ovoid, and this tandem and ovoid, it is used for brachytherapy in case of cancer cervix, right? Now tell me, in case of cancer cervix, please remember that up till stage 2A, the management of choice is surgery, except whenever the tumor is more than equal to 4 centimeters in size. And there are two conditions, there are two stages in which the tumor is more than equal to 4 centimeters in size. One is 1B3 and the other is 2A2. So up till stage 2A, management is surgery, except for stage 1B3 and 2A2. In both these stages, you have to go for chemoradiation. From stage 2B onwards, management is chemoradiation, and actually it is radiotherapy. But in order to make the cells sensitive towards radiotherapy, we are going to use a drug which is cisplatin, which will increase the sensitivity of the cells towards radiotherapy. So I'm not giving any chemotherapy. I'm just giving a drug to increase the sensitivity of radiotherapy. The radiotherapy which you use in case of cancer cervix, it can be in the form of external beam radiotherapy or it can be in the form of brachytherapy. And when I am using brachytherapy, then it is the tandem and this ovoid which I am using to give brachytherapy. Right? Now, important images of ovarian tumors. Now, whenever you get an ovarian tumor where you see that there are hair and there are teeth-like structures, teeth or hair-like structures, it means you are looking at a dermoid cyst. Please remember, a dermoid cyst is the most common germ cell tumor. And the germ cell tumors, they are all found in young age groups, right? Now, when you do an ultrasound of a dermoid cyst, on ultrasound of a dermoid cyst, you can get Rokitansky protuberance, right? So you get a Rokitansky protuberance. On one side, you will see that there is some elevation, some white colored, so there will be a cyst, and on one side you are going to get a raised white area which is called as Rokitansky protuberance. In case of dermoid cyst, I want all of you to remember that there are two more appearances on ultrasound which you can get. One is called as a dot and dash appearance, and the other one is you can get a tip of iceberg appearance. Right now, dermoid cyst is the most common cyst which can undergo torsion, and that is why management of dermoid cyst is cystectomy. Now, a second image which you have to know is that of a dysgerminoma, which a gross specimen of dysgerminoma, a very, very characteristic image where you are going to get fleshy, solid, lobulated, tan colored tumor, and histopathological examination finding in case of the dysgerminoma, which again is very characteristic, where you are going to get a septa, a fibrous septa, and there will be nests of cells. So there will be nest of cells which will be separated by a fibrous septa, and this fibrous septa will be infiltrated by lymphocytes. Next, very important is yolk sac tumor or endodermal sinus tumor. In yolk sac tumor or endodermal sinus tumor, you get a Schiller dual body. What is a Schiller dual body? A Schiller dual body appears very much similar to a glomerulus, where in the center you are going to get a blood vessel. Right, so there will be a central capillary which will be surrounded by the tumor cells, and then there will be clearing. Central capillary, right, this is surrounded by tumor cells, and outside the tumor cells there is clearing, or there is a cystic space. Outside the tumor cells you will get a cystic space. This is a characteristic feature of yolk sac tumor or endodermal sinus tumor, and this is what is called as a Schiller dual body. Then you have granulosa cell tumor. When you are going to look at the histopathological examination finding of granulosa cell tumor, you are going to get Cal-Exner body. The appearance is as such as if there are number of follicles which are present. What is a follicle? A follicle is a primary oocyte which is surrounded by the follicular cells, and that is how a follicle appears, and same kind of appearance you are going to get in case of granulosa cell tumor. It appears as if there are number of follicles which are present. Right, so this is how a Cal-Exner body looks like. Please remember the tumor marker for granulosa cell tumor. It is inhibin B and anti-Mullerian hormone. Right. Next very important point is Krukenberg tumor. Krukenberg tumor, basically it's a metastatic tumor of the ovary, right? And this metastasis, it arises from the primary tumor is coming from the pyloric end of the stomach. From the pyloric end of the stomach, the tumor is going to metastasize via retrograde lymphatic, and it is going to reach the ovary, and it is going to form what is called as Krukenberg tumor. This Krukenberg tumor generally is unilateral. It will have a waxy consistency. The capsule of the ovary will be intact, right? Now, and the shape of the ovary will be intact. And when you are going to see the histopathological examination finding, you are going to get signet ring appearance. That means the nucleus will be pushed towards the periphery, and that is what appears as if it's a signet ring. Right? Now, coming to some miscellaneous images which I want all of you to know. So, in miscellaneous images, the first image which I want all of you to know is that of genital warts. Please remember, genital warts is caused by HPV-6 and HPV-11. And what is the drug of choice for genital warts in a pregnant female? The drug of choice for genital warts in a pregnant female is trichloroacetic acid. Right? Then second image which I want all of you to see is that of an aceto-white area which is appearing on colposcopy. Colposcopy, please remember, it's a magnifying instrument, and this magnifying instrument, the magnification which you get in case of colposcopy is 30 times. In colposcopy, you have to use 3 to 5% acetic acid, and when you use 3 to 5% acetic acid, the normal area is going to appear pink in color, the dysplastic area is going to become white in color, and that is from where you have to take a biopsy, and the metaplastic area appears gray in color. Another question which they ask you is that during colposcopy, if I want to see the abnormal blood vessels, which filter should I be using? The filter which is used to see abnormal blood vessels during colposcopy is a green filter. A green filter is nothing but a green light which you have to switch on. right? Then over here, what you are seeing is coilocytosis. What is coilocytosis? When HPV infects the epithelial cells, then it changes them into coilocyte. What is a coilocyte? In a coilocyte, what you are going to get is, you will see that there is a perinuclear halo. So there is going to be a cell with the nucleus, and around the nucleus, you are going to get a halo. So see over here, very, very characteristic image. This over here was an eosinophilic cell. That means this was a superficial cell and pink colored cell, but around the nucleus I am getting this white space, which is called as a perinuclear halo, right? And when HPV infects the epithelial cells, that is what it changes them into a coilocyte. Please remember, when you are going to do biopsy in a coilocyte, what is it going to correspond to on biopsy? This corresponds to CIN1. Right? Dysplastic cell. This is how a dysplastic cell is going to look like. A dysplastic cell is going to have big nucleus. There will be increased nuclear is to cytoplasmic ratio. Right? That is what is a dysplastic cell appears like. Then coming to this over here, what you are seeing over here, see, these are the normal epithelial cells. And do you think, see over here, that it is appearing as if the normal epithelial cells are very dirty. So it is appearing as if there are lots of dots, which are appearing on the epithelial cells. These dots are nothing but the bacteria which are adhered to the epithelial cell, and such a cell is called as clue cell. And this is what you get in case of bacterial vaginosis. So in case of bacterial vaginosis, you get clue cells, and clue cells, they should be more than 20%, and that is what you get in case of bacterial vaginosis. Very, very characteristic feature of bacterial vaginosis. Please remember, in bacterial vaginosis, there is no inflammation, but the Dodeline bacilli, they are replaced by other bacilli like Gardnerella and like Mobilicus. In case of bacterial vaginosis, when you are going to do saline microscopy, you are going to get clue cells, and the gold standard investigation in bacterial vaginosis is not culture, whereas in Trichomonas and Candida, it is culture. In case of bacterial vaginosis, the gold standard investigation is gram staining. And on gram staining, you are going to take out the Nugent score. Clear to all of you? And this Nugent score was something which was asked in your NEET-PG exam as well, that Nugent score is calculated, or Nugent score is done in which case? So Nugent scoring is done in case of bacterial vaginosis. Now this over here is a typical appearance where it is appearing as if the cervix has a strawberry-like appearance, and this is what is called as strawberry cervix, and this is seen in case of Trichomonas vaginitis. Right? Then over here, what is this? Over here, what you are seeing is a chronic complication of PID. This is a long-term or a chronic complication of PID where you are getting perihepatitis. And this perihepatitis, because of the perihepatitis, you are getting violent string adhesions which are seen between the liver and the anterior abdominal wall, and this is what is called as Fitzhugh-Cutis syndrome. Please remember, Fitzhugh-Cutis syndrome can be seen in any kind of PID, and it is more common with chlamydia. Right? So this is a long-term complication of PID where you are getting violent string adhesions between the liver and anterior abdominal wall, and these adhesions are happening because of perihepatitis, and this is what is called as Fitzhugh-Cutis syndrome. Then I want all of you to look at these cysts over here. These are the three cysts which can be confusing to you. They are present in vulva and vagina. If you see a cyst which is present between labia majora and minora, that means you are looking at a Bartholin gland cyst. Please remember, if a Bartholin gland cyst is symptomatic, then its management is incision and drainage. If a Bartholin gland cyst is asymptomatic, then in that case, you have to look at the size of the cyst. If it is less than 3 centimeters, you have to go for conservative management. If it is more than equal to 3 centimeters, you have to go for incision and drainage. If your question says that there is a recurrent Bartholin cyst, then the management is marsupilization. Right? Please remember, another name for Bartholin glands is greater vestibular glands, and Bartholin glands are homologous to Cowper's gland or bulbourethral gland in males. Now, I want all of you to look at this particular cyst over here. This cyst, first of all, identify this structure over here. But this structure over here is urethra, right? And this opening over here is the opening of vagina, which is called as introitus, right? Now, this particular cyst which you are getting, this cyst is very close to urethra, and this is a paraurethral gland cyst. So, it's a paraurethral gland cyst or a skein gland cyst. Please remember, skein gland is homologous to prostate gland in males. Now, this cyst which you are seeing is not visible on the vulva. What is vulva? That is the name given to female external genitalia. This cyst I am able to see only when I am pulling the vaginal wall. This particular cyst is present in the anterolateral wall of vagina. A cyst which is present in the anterolateral wall of vagina is a Gartner's cyst. Please remember, Wolffian duct's remnant is Gartner's duct, and if a cyst is formed in Gartner's duct, that is what is called as a Gartner's cyst. Now, another thing which I want all of you to understand, I have not brought the images over here. So this opening, see, the opening of vagina is what is called as introitus, right? So vaginal opening is introitus. And please remember, this introitus is covered by a membrane which is called as the hymen, right? So introitus is covered by a membrane. So normally in this hymen is going to have an opening, right? So normally hymen has an opening, and that is how a normal hymen looks like. Now, if there is no opening in the hymen, that is what is called as imperforate hymen, right? And a patient of imperforate hymen presents to you with primary amenorrhea, although she is menstruating, but menstrual blood will not be able to come out. So she will present to you with primary amenorrhea, and on local examination, you will see tensed, bulging hymen, right? And cough impulse is going to be present. Now, in case of imperforate hymen, how do you manage it? You give a cruciate incision on the hymen. You give a cross-shaped incision on the hymen, right? Now, a next problem in the hymen could be that hymen has openings, but there is a septa which is present in between. This is what is called as a septate hymen. Or you can get multiple small openings on the hymen like a sieve, like a channi, and that is what is called as cribriform hymen. Cribriform hymen. These days, they have started asking you images related to hymen as well. So, the images related to hymen also become extremely important. Now, the last image which I want to show you is related to your tubal ligation. Please remember, the site for tubal ligation is isthmus. Why is isthmus the site for tubal ligation? Because of uniform muscle thickness in the isthmus. Now, when I'm doing tubal ligation can be done in a female who hasn't had delivery in recent past. If a female did not have any delivery in recent past, obviously I'm going to go for laparoscopic tubal ligation. But if you are doing a postpartum ligation, how do you define a postpartum ligation? A postpartum ligation is when you are doing ligation after 24 hours until 1 week after delivery. Whenever you are doing a postpartum ligation, beta, please remember, laparoscopic ligation cannot be done. Why it cannot be done? Because all of you know what is the height of the uterus immediately after delivery. The height of the uterus immediately after delivery is just below the umbilicus. So common sense tells me, where am I going to put a laparoscope? The moment I will put a laparoscope, it is going to lead to uterine perforation. That is why in the postpartum period, you cannot go for laparoscopic tubal ligation, but what you can do is a mini laparotomy. Now, when you are doing mini laparotomy, the technique which you are going to use for tubal ligation is what is called as Pomeroy's technique. What is this called as? Pomeroy's technique. In a Pomeroy's technique, you are going to make a loop out of the isthmus of the fallopian tube, and you are going to tie a ligature, and then you are going to cut the loop. Now, there is something which is called as modified Pomeroy's technique and something which is called as Pomeroy's technique. The only difference between Pomeroy and modified Pomeroy, although in both of them I have to use absorbable suture. In case of original Pomeroy, the suture which was used was chromic catgut. And in modified Pomeroy, the suture which is used is plain catgut. Plain catgut, it has a quicker absorbable time, so it dissolves quickly, and that is why we prefer using modified Pomeroy, because the sooner this suture is going to dissolve, the sooner the two parts of the tube are going to separate, right? So I'm going to do a ligature at the base. I'm going to make a loop. I'm going to tie it with the catgut. Then I'm going to cut this part of the loop and I'm going to send it for histopathological examination to be sure that I have ligated the fallopian tube. Why? Because at the cornua of the uterus, there are 3 tube-like structures attached, and they are round ligament, fallopian tube, and ovarian ligament. That is why whenever we are doing tubal ligation, whatever part of the tube we are cutting, we are sending it for histopathological examination to be sure that it is the tube which we have ligated. So they can show you this image. This image over here is a Pomeroy's technique, or you can also call it as a modified Pomeroy's technique, because in both of them you have to make a loop and you have to do a ligature. Now, sometimes some books have created a confusion that if it is a single ligature, it is Pomeroy's. If it is a double ligature, it's a modified Pomeroy's. Nothing like this. Right? The only difference between Pomeroy's and modified Pomeroy's is in the nature of the suture which you are using. Now, remember that this over here is laparoscopic ring applicator, and with the help of laparoscopic ring applicator, you use a Fallop ring, and this Fallop ring is placed at the base of the loop, right? So that's the difference between laparoscopic ligation and between mini laparotomy. In mini laparotomy, you are making a cut, you are taking out the tube, you are making a loop, and you are tying it with catgut. In case of laparoscopic tubal ligation, with the help of the laparoscopic ring applicator, you make a loop and then you put the Fallop ring. Please remember, laparoscopic tubal ligation cannot be done in the postpartum period. It can be done only as interval ligation. That means after 6 weeks of delivery. Mini laparotomy can be done in postpartum period also and in interval period as well. Right? So these were all the images which I wanted you to know in Obs and Gynae. Please let me know how much was this beneficial to you in the comment section. I'll be waiting for your comments. All the best to all of you for your exams. And after your exams, again, I'll be waiting to hear from you. Take care. Love you all.